transformative.
The COVID-19 pandemic has changed our lives. UP Manila as the Health and Sciences Center is expected to carry a significant burden in terms of patient care and, more importantly, take the lead in looking for solutions. UP Manila as an institution has responded in many ways. The PGH, or the Philippine General Hospital, serves as one of the COVID-19 referral centers of DOH, committing its health workforce to serve. The UP-PGH COVID-19 Bayanihan na Operations Center, manned by volunteer faculty, students, and staff as they respond to patients and donation queries. The COVID-19 pandemic has changed our lives. UP Manila as the Health and Sciences Center is expected to carry a significant burden in terms of patient care and, more importantly, take the lead in looking for solutions. UP Manila as an institution has responded in many ways. The PGH, or the Philippine General Hospital, serves as one of the COVID-19 referral centers of DOH, committing its health workforce to serve. The UP-PGH COVID-19 Bayanihan na Operations Center, manned by volunteer faculty, students, and staff as they respond to patients and donation queries.
Welcome participants, speakers, session chairs, and guests to the 3rd National Patient Safety Congress with the theme Synergized Approach to Patient and Health Worker Safety. This Congress is organized by the University of the Philippines, Manila, in support of the Sustainable Development Goals.
Welcome to the 3rd Patient Safety Congress, organized by the University of the Philippines, Manila.
Please be reminded of the following rules during the Zoom webinar session. This event is being recorded. You may type your questions in the Q&A box at any time during the lecture. The meeting facilitator will take note of them for discussion during the Q&A session. Kindly revise your name to include your institution. An example for renaming is found here in the slides. The Congress is divided into 3 tracks, namely the Executive or Leadership track, the Clinical track, and the Innovations or Education track. The third Patient Safety Congress has been applied for PRC CPD units for the following professions: medicine, nursing, pharmacy, dentistry, midwifery, and physical therapy. You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. And lastly, as stewards of patient safety, we are inviting you to sign our pledge of commitment to patient and healthcare worker safety. Please access the link found on your screen.
Please all rise for the singing of the Philippine National Anthem.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang mag-ibig, ewas ng sigahanan, alam ng puso, sa dikit mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa manlulupin, di ka pasisingil, sa nagatang tutok sa simoy at sa langit mong bagaw, ay hinatang tulakaw, sa pagkayang minamahal, ang isang ng matawad mo'y tagumpay na nag-iingin, ang bituin at araw niya kailan ang may magdidinig, luman ang araw ng walhagin pagsinta, buhay langit sa piling mo. Ang inigaya ng pagkay mga api, ang mamatay ng dahil sa'yo.
Please be seated. To start our Congress, let us all welcome Dr. Carmencita D. Padilla, Chancellor of the University of the Philippines, Manila, for her opening remarks.
Dr. Graham Perry Harrison, Officer in Charge, WHO Philippines Country Office, Professor Jenny Baguio, Overall Chair of the Third National Patient Safety Congress, participants, speakers, guests, good morning. It is a pleasure and honor to welcome you all to this year's edition of the Patient Safety Congress. In celebration of the 2022 International Patient Safety Day, the University of the Philippines, Manila, once again holds this meeting to raise global awareness on patient safety and calls for solidarity and united action among all stakeholders. This edition will build on the outputs of the 2 previous congresses. The first in 2015 presented the foundations of patient safety, while the second in 2019 highlighted the innovations and evidence-based practices. With the new challenges posed by the pandemic,
underscoring the prevailing issues in healthcare systems. The 2022 National Patient Safety Congress places the spotlight on the healthcare workers, and rightfully so, because a safe, protected, and secure health workforce is central to patient safety. This third conference, with the theme Synergized Approach to Patient and Health Worker Safety, capitalizes on the heightened awareness of healthcare workers' role in the changing healthcare landscape. It is reassuring that this two-day assembly will advocate for policy and practice improvements to enhance human resource safety for health with the goal of improving patient and worker safety. We are buoyed up seeing stronger patient safety initiatives anew after 2.5 years of fighting the COVID-19 crisis. Among our takeaways from the pandemic, it is the highlighting of crucial patient safety issues, not only in the hospital, but in other settings. We are optimistic that the convention will lead to renewed efforts to secure broader commitment of putting safety and quality in the heart of patient care to ensure that this system remains at the forefront of clinical excellence. Also, we are inspirited that the Patient Safety Congress is the only event to bring together all the stakeholders across the healthcare spectrum to debate the most critical patient safety issues and share practical solutions. In this forum, attendees can choose from the simultaneous sessions that offer pragmatic real-world insights to take home and implement in your organization or health facility. Choose speakers who will engage the participants with their vision for safer care that transcends care settings. Attendees can build relationships with smart, devoted people who improve safety throughout the world and forge networking and collaborative opportunities to promote a national patient safety culture. I thank all those gathered here for a two-day symposium. You who are passionate about ensuring safe, equitable care for all, and those who continue to shape smarter, safer care for patients in different settings, hospital, outpatient, or at home. Patient safety is at the heart of every health program, service, or advocacy. As a national health university, UP Manila shares this mission and goal with other institutions and organizations and forges solidarity with them to make patient safety an imperative in any health setting. When patients and health workers are safe and secured, the hospital, outpatient setting, and home will become havens of healing and peace. Maraming salamat po at mabuhay tayong lahat.
Thank you very much, Chancellor Padilla, for giving perspective for our National Patient Safety Congress. To give an overview of the Congress and her welcome remarks, let us now welcome Dr. Jennifer T. Pagio, overall chair of the Third Patient Safety Congress. Please give her a virtual round of applause.
Thank you, Chancellor Padilla, for your unwavering support and for opening the third National Patient Safety Congress. I am excited to give you an overview of our Congress proceedings over the next 2 days. Although this was initially envisioned by Dr. Crisostomo and myself over several Zoom calls since 2019, I am deeply proud of the program we are sharing with you today that was carefully designed by our scientific committee, led by Dr. Diana Tamondong La Chica, and will be given life by our roster of exemplary speakers. The first Congress in 2015 presented the foundations of patient safety, while the second Congress in 2018 highlighted innovations and evidence-based practices. With the new challenges posed by the peri-pandemic era, this underscored the prevailing issues in healthcare systems. The 2022 National Patient Safety Congress will place the frontliners in focus. The third Congress capitalizes on the heightened awareness of healthcare workers' role in changing healthcare landscape with the theme, Synergized Approach to Patient and Healthcare Worker Safety. Our Congress underscores the premise that patient safety cannot be achieved without the safety of the multi-professional healthcare workers. The fully packed two-day Congress will be started with a global and local perspective and call for the synergy of safeties by the World Health Organization Philippines. To immerse ourselves with the most important developments, issues, and concepts related to healthcare worker safety, we go on separate tracks into 3 sessions that elucidate on the unique perspectives of the healthcare leader, administrator under executive leadership track, the practitioner under the clinical track, and the educator researcher under the innovations track. For day 1, we will have the first simultaneous session on implementing occupational health and safety standards for the healthcare workers, which focuses on current local and international occupational health and safety standards. The aim for this session is to help identify policy gaps and generate insights for policy and practice changes. This will be immediately followed by the second simultaneous session, protecting and promoting equity in health workers. This puts the spotlight on the major issues brought forward by the pandemic, the physical and psychological harm experienced by healthcare workers. This session investigates the scale of harm experienced by healthcare workers, such as harassment, violence, and other organizational disparities, and useful mechanisms to prevent and minimize them through equitable and sustainable practices and policies across settings. The Congress also hosts e-posters and video presentations of research, quality improvement initiatives, and best practices on patient safety with our champions from institutions across the country. Your day 2 starts with a quick recap, and within your chosen tracks, watch video presentations. You will also be able to take time to view our e-posters on the Congress website. The link will be shared with you shortly. After the video presentations and e-poster viewing, the input continues with the third and last simultaneous session on ensuring psychological safety and well-being in the healthcare workplace. This greatly complements the previous 2 simultaneous sessions by focusing on promoting psychological safety and well-being in dealing with patient safety incidents, stresses surrounding the peri-pandemic context. The session looks into best practices in managing adverse events in heightened situations, promoting error reporting and systems learning, preventing the consequence of the second victim, and in applying mindfulness in promoting well-being and joy in the workplace. After a series of simultaneous sessions, we will come together again in the closing plenary with a session on forging partnerships with patients and families in improving safety in health facilities. At the core of what we do and why we do what we do is to ensure that we provide safe, high quality, and equitable healthcare to our clients, individual patients and their partners, healthcare workers, families, and communities. Understanding the synergistic relationship of patients and healthcare workers means that we are equal partners in care, and the need to be equipped in evidence-based and patient-recommended approaches to care provision are essential. Finally, we will end the Congress with our declaration of commitment to patient and healthcare worker safety. We invite you to signify your commitment and apply our learnings and translate our insights from the Congress into actions that can positively impact patient and health worker safety. The link to the pledge will be shared with you later. With that, I would like to start our session by introducing our opening plenary on the synergy of safeties, patient and health worker safety. To ground our Congress and in celebration of the International Patient Safety Day, let us all give a virtual welcome on our platform to the officer in charge of the World Health Organization Philippines, Dr. Graham Perry Harrison. Dr. Harrison, the virtual floor is yours.
Thank you very much, Chair, and thank you for inviting WHO to be part of the third National Patient Safety Congress, which is focusing on a synergized approach to patient and health worker safety. And I have been requested to provide an address related to this topic. So please allow me to share my screen. Right. Hopefully you can see that all right. So as this is the start of the Congress, allow me to spend a few minutes reminding or recapping about the importance of patient safety and its impact when things go wrong, to set the scene. Patient safety is one of the most fundamental aspects of healthcare delivery, which is essential to achieve universal health care and move towards the UN Sustainable Development Goals. Patient safety is a framework of organized activities that creates cultures, processes, procedures, behaviors, technologies, and environments in healthcare that consistently and sustainably lower risks, reduce occurrence of avoidable harm, make error less likely, and reduce its impact when it does occur. Adverse events or safety mishaps may result from problems in practice, products, procedures, or systems, but we are trying to achieve overall is first to do no harm. Every point in the process of caregiving contains a certain degree of risk to patient safety. The global landscape of healthcare is changing, with health systems becoming increasingly complex, and we're operating in increasingly complex environments as well. So while we have new treatments, technologies, care models that can all have therapeutic potential, they also pose new threats to safe care. And therefore, the processes and other steps that we need to take to try and ensure patient safety also need to change and continuously improve. And fundamentally, particularly of relevance to the discussions at this Congress, healthcare is about trained people, our health workers, providing services for other people, our patients. And as such, there is a possibility that providing these services might not only adversely impact patients, but also healthcare workers as well. And of course, if healthcare workers are not functioning optimally, then that can affect our patients. So there's a very direct relationship. Allow me to recap on a few brief numbers so we know the scope of the problem. In low and middle income countries, every minute it is estimated that 5 patients die because of unsafe care. In high income countries, 1 in 10 patients is harmed while receiving hospital care, and nearly half of these are considered avoidable. In studies on OECD countries, they identified that 4 out of 10 patients are harmed in primary and ambulatory care settings. And the direct costs of safety lapses, including additional tests, treatments, and healthcare, found to be around about 2.5% of total health expenditure. And these safety lapses resulting in hospitalizations each year may account 6% of the total hospital bed days and more than 7 million admissions in the OECD. And that's just for safety lapses across 5 common chronic conditions like diabetes, hypertension, heart failure, chronic obstructive pulmonary disease, and asthma. In 2018, a study by the National Academy of Sciences estimated that in low and middle income countries, between 5.7 and 8.4 million deaths occur every year from poor quality care, which means that quality defects in health services cause 10 to 15% of the total deaths in these countries. A large proportion of this estimate relates to ineffective care, but just focusing on unsafe care, it's estimated to account for 2.6 million of these deaths. The resulting costs of lost productivity alone amount to $1.4 to $1.6 trillion each year. However, these estimates concern poor quality care and do not include those impacted by a lack of access to health services for all amenable conditions. Indeed, if we include those who cannot access care, the estimated lost productivity is around 4 times the figures that I've just given. So moving towards UHC, which is of course a central theme, a central thrust of global health policy, it is critical to ensure that we do not just focus on access, Quality and specifically safety are centrally important for achieving UHC. And if we do not, billions of people will have access to health care, but it will be of such low quality that it cannot help them, and indeed will often harm them. So turning now to focus on the well-being of the workforce, which is a central component, as I've said, of actually ensuring safe services for patients. Now, we could quite legitimately focus on this from a more traditional occupational health and safety perspective. It's quite valid to do that. And it has, from a very fundamental level, been recognized for its importance. And for example, in the 1948 Universal Declaration of Human Rights, it includes a provision in Article 23 on the right to work, which includes just and favorable conditions of work as a fundamental human right for any worker. Many important subsequent international conventions, resolutions, and instruments, including the 2030 Agenda for Sustainable Development and its SDGs, have called upon governments and other stakeholders to provide safe, secure, and supportive working environments for all workers. The health, safety, and well-being of health workers is a legal and moral responsibility of governments and a prerequisite for the effective provision of essential health services, as well as responding to public health emergencies such as pandemics. But if we look specifically at declarations or other instruments relating to patient safety, we will see, for example, in the World Health Assembly resolution in 2019, that it not only recognizes the importance of education and training and continuous professional development to build and maintain a competent, compassionate, and committed healthcare workforce, but it also recognizes the need to build appropriate, enabling, and safe working environments that optimize the delivery of safe health services and promote a safety culture. The Jeddah Declaration on Patient Safety, also in 2019, arising from the 4th Global Ministerial Patient Safety Summit in 2019, and building on the Tokyo Declaration on Patient Safety the year before, provides 11 points that call for action. And point 6 directly relates to the safety of the health workforce and its paramount relationship to patient safety, and identifies the importance of countries adapting national policies in a number of areas. And I won't go into these in detail, but it does recognize the importance of workforce safety, both physical and psychological. So turning now to consider the work-related hazards impacting on health worker safety. I mean, there are many factors and potential hazards that we can identify in the health workplace that are related to providing health services. There are several listed here. They range from biological and chemical hazards, various types of physical hazards, and they also importantly include mental health and exposure to violence. And I'd like to examine 3 of these a little bit more this morning. The first is looking at biological hazards. And I suppose what's on everybody's mind over the last 2 years is COVID-19. So let's look a little bit more at that. From the figures that we have on COVID-19, up to earlier this month, over 5 million cases of COVID-19 has been reported to WHO among healthcare workers globally. From the start of the pandemic up to the middle of 2021, over 6,600 healthcare workers were reported to have died from COVID-19. But both of these numbers are considered to be significant underestimates. In October last year, WHO published a working paper that used a few methods to estimate the true healthcare worker deaths in that timeframe. And the estimated number ranged from 80,000 to 179,000 deaths. But if we try to quantify the risk of COVID-19 to healthcare workers in the workplace, this is much more complex. There is a living systematic review on COVID relating to many aspects of COVID-19 up to May this year. It includes over 8,500 citations. It does show an association between PPE use and decreased risk of infection. But the review itself didn't look at whether or not infection was acquired in the workplace. There are a number of individual studies that report on whether infections acquired in the workplace through, for example, reporting forms or looking at the proportion of healthcare worker infections compared to the proportion of healthcare workers in the population. And there is evidence of increased risk and workplace acquisition of COVID-19, although most of these studies relate to earlier in the pandemic. Around this time in 2020, so earlier in the pandemic, WHO reported that while health workers represent less than 3% of the population in the large majority of countries, and less than 2% in almost all low and middle income countries, around 14% of COVID cases reported to WHO are among healthcare workers. And in the same country, in some countries, the proportion could be as high as 35%. However, as time has gone on, the data availability and quality of the data have been challenging. And of course, the situation is much more complex now with vaccination, changing variants, and many other factors. So it is usually not possible to establish whether health workers were infected in the workplace or in community settings. Nevertheless, there is clearly risk here, and it has impacted on the lives of many, many health workers and their families. Looking now at mental health, I mean, this is one clear area where there has been impact from COVID-19. But in general, there is evidence that physicians suffering from depressive symptoms are associated with increased risk of medical errors. And there's a small footnote on the slide here which quotes one study. But I don't think we can underestimate the importance of mental health, with so many factors that may adversely impact on workers' mental health. And related to this is workplace burnout. 1 in 3 health workers in high-income countries suffer from work-related burnout at the workplace. This can be related to many factors, including high workloads, long hours, strained interpersonal relationships in the workplace, and others. And I'm sure that many of you can relate to these factors and other factors as well over the last 2.5 years. Even just the stress and uncertainties about COVID-19, particularly in the earlier periods when we didn't have that much knowledge about COVID-19, we didn't have vaccines, and that I'm sure was a very stressful time for any health workers trying to deliver services to patients. The last area I would like to highlight is workplace violence. Globally, 6 out of 10 health workers report experienced violence at the workplace. Now, this does include those working in areas of conflict and war. So practicing in these areas, of course, involves a number of potential risks from fires, explosions, and so forth. But nevertheless, this is a high proportion of workers who experience violence at their workplace in general. Too many workers across the world face physical and psychological violence in their daily work, as well as in emergency situations. Female health workers are particularly vulnerable. These threats directly affect morale and hamper retention of health workers and can lead to reductions in patient safety and quality of care. So I would like now to focus on 5 key action areas to improve health worker safety and patient safety. And I've drawn these from a charter that was issued in 2020 on health worker safety, a priority for patient safety. The first of these is to establish synergies between health worker safety and patient safety practices, policies, and strategies. Health worker safety and patient safety are inseparably connected practice domains. A shift within this context, priority actions and interventions need to include developing linkages between occupational health and safety, patient safety, quality improvement, and infection prevention and control programs. To include health and safety skills in personal and patient safety into education and training programs for all health workers. To incorporate requirements for the safety of health workers and patients in healthcare licensing and accreditation standards. integrating staff safety and patient safety incident reporting and learning systems, and to develop integrated indicators of patient safety, health worker safety, and quality of care. In the second area, we look at addressing issues related to the occupational health and safety of workers, requiring a programmatic approach throughout the health system. WHO recommends developing and implementing national programs for occupational health and safety of health workers as part of overall efforts to strengthen health systems. Priority actions and interventions need to include developing and implementing national programs for occupational health for health workers in line with national occupational health and safety policies. To review and upgrade, where necessary, national regulations and laws for occupational health and safety to ensure that all health workers have regulatory protection of their health and safety at work. To appoint responsible officers with authority for occupational health and safety for health workers at both the national and facility levels. To develop standards, guidelines, codes of practice on occupational safety and health, particularly relating to the provision of healthcare, and to strengthen intersectoral collaboration on health worker and patient safety with appropriate worker and management representation, including gender, diversity, and all occupational groups. Thirdly is the need to protect health workers from violence in the workplace. Now, violence in the workplace may manifest as inequality, abuse, harassment, discrimination, stigmatization, and conflict, as I'd mentioned previously. But any form of violence against health workers is unacceptable. And within this context, priority actions and interventions include promoting a culture of zero tolerance to violence against health workers, ensuring labor laws and other legislation to prevent violence against health workers, ensuring that the regulations, policies, and mechanisms are adopted and implemented effectively to prevent violence and to protect health workers, and to implement mechanisms to enable free and confidential reporting and support for any health worker who faces violence. Fourth, we must also improve mental health and psychological well-being. Many health workers operate in high demand, high stress, high risk work settings for long hours. Health workers involved in public health emergency response are further exposed to exertion from extra hours and additional safety challenges. Health workers should be assured of access to psychological support and be able to report safety concerns without fear of retaliation. Priority actions and interventions include the need to establish policies to ensure appropriate and fair duration of deployments, working hours, rest breaks, to define and maintain safe staffing levels within healthcare facilities, to provide insurance coverage for work-related injury and illness, including mental health, especially for those working in high-risk areas, and to establish a blame-free and just working culture, including protection from punitive action on reporting adverse safety events. And of course, provision of access to mental wellbeing and social support services is a very important aspect of this as well. And lastly, we must protect health workers from physical and biological hazards. Health workers face multiple physical and biological and ergonomic hazards, including exposure to infections, sharps, falls, radiation, chemicals, fire, and electrical hazards, musculoskeletal disorders due to poor ergonomics in handling patients and lifting heavy equipment. So priority actions and interventions need to include implementing minimum patient safety, infection prevention and control, and occupational safety standards, ensuring the availability of personal protective equipment at all times is relevant to the roles and tasks performed in adequate quantities and appropriate fit and of acceptable quality, ensuring an adequate locally held buffer stock of PPE, and ensuring adequate training on the appropriate use of PPE and safety precautions. We must ensure adequate environmental services, water, sanitation, hygiene, disinfection, ventilation. I mean, even in this day and age, we have a lot of our health facilities that do not have a decent water supply or suitable sanitation facilities. Those very basic things are not available in a number of health facilities. Vaccinating all health workers at risk is another key aspect, and providing adequate resources to prevent health workers from injuries and harmful exposure to chemicals and radiation. Now, what can be done? And there are many parties who could be involved in this, or should be involved in this. It includes patients, family members, and caregivers. And of course, the onus on patients and their families is to make sure they provide accurate information about their health and medical history, and that they raise safety concerns with their health providers. This is not only in their own interests, but it's particularly relevant to some types of infections and other things where it may actually present a risk to the health professional involved. Patient safety and civil society organizations advocating for changes in systems, practices, and policies to achieve safer healthcare conditions. And professional associations not only can do that, but also are in a position to be able to speak up against unsafe working conditions and violence against health workers. Academic or research institutions, we do need the continued generation of good evidence in the area of health worker safety and patient safety, including infection prevention and control. And this is very important to inform policy, regulations, and standards of practice. As I indicated earlier, the way we provide care, our processes and procedures are continually changing. So we cannot rely on old evidence, which may no longer be relevant to the current situation. Of course, policymakers, regulators, parliamentarians, external accreditation or evaluation organizations all have the responsibility for contributing to or developing and promoting policies and legislation for the protection of health worker and patient rights. Our healthcare leaders, administrators, and managers need to create a supportive and safe working environment and a suitable organizational culture to implement innovative safety practices based on human factors and ergonomics, and to handle issues constructively when health workers raise concerns about their health. And of course, most fundamentally, health workers themselves. Health workers do have an obligation to take care of their physical and psychological health, and to be honest about your health and seek care for yourself rather than denying or ignoring it. And if we're really honest, I think most of us would know full well that most health workers put others before themselves, which is appropriate considering what we do, but we do not take enough care of ourselves. We're not honest and say, we're actually sick today and shouldn't go to work. Instead, we try and press on, and we try and do the work that's expected of us. And that has its toll. It can affect you physically, but also particularly mentally and psychologically as people get worn out from not being able to recover properly or having proper treatment for conditions. And the stress of actually providing the services for others just compounds on top of their own health issues. So I'll end the presentation here. Sorry, I just have to find the button to do so. There we are. So clearly we have important linkages between the health and well-being of health workers and patient safety. And effectively engaging on this involves multiple parties who need to contribute effectively to help keep health workers safe. Looking through the program, I'm very pleased to see that most, if not all, of these elements I have mentioned today have been included in different parts of your program. So I'm sure you'll have a number of interesting further discussions. Thank you very much for listening, and I wish you well for the remainder of the Congress. Bye.
Thank you, Dr. Harrison, for sharing with us the fundamentals and implementation of patient and health worker safety in different practice settings and the role of different stakeholders to promote patient and health worker safety. For participants requesting for attendance sheets, we will take note of your Zoom attendance during the event and will send e-certificates at the end of the Congress once you have accomplished the evaluation form. So just a few reminders for day 2. Please enter the Zoom link of your chosen track on time at 8 a.m. You may view and vote for the poster presentations and advocacy videos through our website starting today. So this will be the end of our opening plenary session, and further reminders are posted right after.
The Congress is divided into 3 tracks, namely the Executive or Leadership track, the Clinical track, and the Innovations or Education track. The third Patient Safety Congress has been applied for PRC CPD units for the following professions: medicine, nursing, pharmacy, dentistry, midwifery, and physical therapy. You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. And lastly, as stewards of patient safety, we are inviting you to sign our Pledge of Commitment to patient and healthcare worker safety. Please access the link found on your screen.
Please take note of your tracks. So for the parallel sessions, again, we have 3 tracks, and the first is on executive and leadership. The Zoom link is shared through your emails and sent in the chat box. Those joining the executive leadership track may make use of the link found in the chat box. Next is on innovation and education track. Again, the link was sent to you through your email and here in the chat box. Please copy the link so that you can transfer to the separate Zoom session. Please take note that participants cannot transfer between tracks, and all session talks will also be made available to you in the Congress website. For the clinical track, please stay in this Zoom session.
The University of the Philippines. The only Philippine university to be named in the top 100 universities in Asia. This state-run institution is a paragon of education steeped in history and culture. The University of the Philippines system is composed of 8 universities around the country. The oldest of which is the University of the Philippines, Manila, the birthplace of the UP system in 1908 in Padre Faura Ermita. Its oldest unit, the Philippine Medical School, later renamed to UP College of Medicine, opened in 1905, followed by the Philippine General Hospital in 1907. From the College of Medicine evolved other colleges and units that diversified the university's course offerings. In 1948, UP was transferred to Diliman, Quezon City, leaving behind some health colleges and the College of Arts and Sciences. In 1976, the School of Health Sciences was created in Leyte to offer a community-based, ladderized health education that aimed to help increase the availability of trained health workers in the province. 2 satellite campuses of the school were strategically set up in 2 other remote and underserved provinces, namely Baler Aurora and Coronadal, South Cotabato. The creation of the Health Sciences Center in 1977 brought together all the health units under one roof. The center was renamed to UP Manila in 1983. Today, UP Manila is the recognized pioneer and leader in health education, research, and public service in the Philippines. Among its pioneering programs are university-wide BS Nursing, Master of Arts in Nursing, PhD Nursing, Master of Health Professions Education, Integrated Arts and Medicine, degree programs in Public Health, MD PhD, MA Health Policy Studies, MS Health Informatics, MS Genetic Counseling, PhD in the Health Sciences by Research, and the only ladderized midwifery, nursing, and medicine degree program of the School of Health Sciences. UP Manila's credentials have led to its being the partner of choice of the World Health Organization, Department of Health, Department of Science and Technology, Commission on Higher Education, and other local and international groups to achieve health reforms. UP Manila is the only campus in the UP system that offers education, research, and training in a wide array of health disciplines and professions. The university offers courses in medicine, nursing, pharmacy, dentistry,
Allied Health Sciences,
public health, health professions education, community health, and the arts, natural, and social sciences. The competency-based curriculum makes it stand out among the other schools. Since 2014, in compliance with the Philippine Qualifications Framework, the colleges are now transitioning to Outcome-Based Education, or OBE. It enables the well-rounded development of students and unlocks their full potential as both health professionals and dedicated Filipinos. UP Manila educates the brightest students in the health professions and allied social science disciplines. Its students consistently top licensure examinations and assume positions of leadership and influence in government, the private sector, academe, non-government sector, and the community, giving them opportunities to shape national policies and programs on health. UP Manila is a pillar in the field of health research. UP Manila ensures that its faculty, staff, and students engage in research as a tool for health reforms. to enhance education and complement its public service role. With the help of the National Institutes of Health, the center of and coordinating body for all researches in the university, UP Manila's researches have served as basis for national policy formulation and program planning. UP Manila's firsts in health research and policy include Republic Act 9288, the Newborn Screening Act of 2004, RA 9709, Universal Newborn Hearing Screening and Intervention Act of 2009, RA 10747, Rare Disease Act of the Philippines in 2016. Other advocacies include the studies on liver diseases that led to the mandatory vaccination of newborns against hepatitis B, commercialization of Lagunti and Sambong as proven effective medications for cough and colds based on the results of the National Integrated Research Program on Medicinal Plants, the Ventilator Project, and the Vision Screening Project for newborns and school children, all of these for healthcare improvement. Strengthening this role is its public service function rendered through the Philippine General Hospital, its community and volunteer programs, and scholarly and technical assistance to the government, private sector, and civil society. As the Philippines' biggest government and tertiary hospital, the PGH sees more than 500,000 patients a year from all over the country. It trains thousands of health students and health professionals from within and outside the university. Among its innovative programs are on child protection and poison control and management. Volunteerism is strong at UP Manila. From the very beginning, students are ingrained with their role as public servants. Through the ugnayan ng pahinuod, faculty, students, staff, and alumni volunteers provide health and socio-cultural services that benefit depressed communities and indigent Filipinos. And to further reach out to the larger society, UP Manila offers the Community Health and Development Program and other community-oriented programs. This combination of excellent education, relevant research, and public service has produced thousands of exemplary doctors, nurses, dentists, pharmacists, public health experts, rehabilitation workers, paramedical workers, and more. With more than 100 years of excellent leadership in health, UP Manila is keeping itself nationally relevant and globally competitive by being at the forefront of Philippine health. The challenge may change, but UP Manila's response will be certain, excellent, relevant, and transformative.
Welcome to the third Patient Safety Congress organized by the University of the Philippines, Manila. Please be reminded of the following rules during the Zoom webinar session. This event is being recorded. You may type your questions in the Q&A box at any time during the lecture. The meeting facilitator will take note of them for discussion during the Q&A session. Kindly revise your name to include your institution. An example for renaming is found here in the slides. Welcome to the third Patient Safety Congress organized by the University of the Philippines, Manila. Please be reminded of the following rules during the Zoom webinar session. This event is being recorded. You may type your questions in the Q&A box at any time during the lecture. The meeting facilitator will take note of them for discussion during the Q&A session. Kindly revise your name to include your institution. An example for renaming is found here in the slides.
Good morning and welcome everyone to the clinical track session, which is one of the simultaneous sessions in implementing occupational health and safety standards for health workers. So I am Monette M. Loquias, a pharmacist and a professor at the UP College of Pharmacy, and I will serve as your session chair for today. So the clinical track is specifically designed for participants who provide patient care or perform activities in support of patient care in both inpatient and outpatient settings. So for our session, we are fortunate to have with us multi-awarded healthcare professionals in their respective fields to share best practices and their experiences in promoting safety in the workplace. So we will start by listening to our three speakers, which will be followed by a question and answer session. So I enjoin everyone to take note of their questions per speaker. You may actually start sending your questions via the Q&A box if you can see it in your screen, and we will be collecting this and read it later during the Q&A. Please do identify the speaker to whom the question is addressed. So let me now introduce our first speaker. Dr. Ana Bella Elizabeth R. Borromeo is a nurse with 2 master's degrees and a Doctor of Philosophy degree from the George Washington University, University of Texas Health Science Center, and Texas Women's University, respectively. She has earned various recognitions, both here and abroad, for her competence, commitment, and exemplary service. Very recently, she is awarded as the Outstanding Nurse by the Professional Regulation Commission in 2022. At present, she serves as the Head of Quality and Patient Safety of the Metro Pacific Hospital Holdings, Inc. Ladies and gentlemen, let us now welcome, with a virtual round of applause, Dr. Annabella Elizabeth R. Borromeo. Dr. Borromeo.
Good morning. Thank you for this opportunity to speak about this very important topic. I have no COI or conflict of interest to declare, but I want to let you all know that I do work at Metro Pacific Hospitals, which is an aggregation of 19 hospitals all over the Philippines. It is the largest healthcare network in the Philippines, counting Makati Med, Manila Doctors Hospital, Asian Hospital, in its stable of hospitals. At the end of this presentation, let me just fix this. At the end of this presentation, you should have some answers to the following questions, enough to be able to think more deeply about and hopefully act on what you heard today. So here are some of the questions. Why is it imperative that interprofessional collaboration be made the standard for ensuring clinical workplace safety? Number two, why should the days of the one-man show in worker safety be numbered? Three, how does the silo mentality negate clinical workplace safety? How are unsafe acts differentiated from unsafe conditions? And what is parallax, and how does understanding of this concept contribute to finding a true motivation for interprofessional collaboration? Whether we consider patient or worker safety, like excellence, it is never an accident. It is always the result of high intention, sincere effort, and intelligent execution. As Aristotle indicated many years ago, it represents the wise choice of many alternatives. Choice, not change, determines our destiny. Workplace safety is not a one-man show. The limited perspective that a single individual is responsible for ensuring workplace safety is now almost laughable because it makes the mandate of securing worker safety an almost impossible task. Nor should siloism be allowed to continue to disrupt attempts at worker safety. Siloism or a silo mentality occurs when certain departments in an organization do not share information or knowledge with other departments. Like silos that separate different types of grain, the term is now used as a metaphor for separate entities that stockpile information. Thus, the silo itself contributes to the lack of workplace safety among other negatives. Let's first differentiate unsafe acts from unsafe conditions. Unsafe acts are worker behaviors that are exhibited and are potentially harmful. The act may be unconsciously performed without active knowledge of the safety consequences. In this situation, the issue is simply a lack of knowledge and can be easily addressed by training. However, some acts may be done with malicious intent. Thus, training will be inappropriate intervention. In instances such as these, compulsory brainstorming may be key to finding a solution. Therein lies the utility of an interprofessional approach. In this instance, the more cooks and enhance the broth, so to speak, because a holistic approach or a holistic solution that incorporates many different perspectives is possible. On the other hand, unsafe conditions are scenarios in the workplace that are potentially harmful, and the longer they are allowed to exist, slowly it becomes normalized and eventually are no longer recognized as risks. Both unsafe acts and condition impact workplace safety. In identifying unsafe acts or conditions, three actions need to occur. First, we identify potential hazards or problems which could occur. Two, we perform risk assessment with scores that are based on severity and frequency. And 3, we prioritize mitigation of those identified as the higher risk or the highest risk. Again, interprofessional collaboration keeps the process honest and safe inherently, as safeguards are put in place so that risk is avoided, or by the control method where risk is mitigated for systems or by systems for safe execution. But the question is, why is there a need for more pairs of eyes? A simple to determine why the perspective is more robust can be conducted when one closes one's eyes or one eye to view an object like a strawberry, or for that matter, a finger. Each of the eyes presents a different perspective, but when both eyes are opened, a holistic 3D picture of the object being observed is obtained. This perspective is called parallax. And this understanding is crucial to why teamwork can be optimized to obtain the best results. Parallax is the difference in the apparent relative position of objects when viewed from different perspectives. This understanding of parallax can be extended to viewing an unsafe condition from different perspectives. That comes with the synergy obtained from the lens of different disciplines. Thus, there is increasing evidence that interprofessional teamwork not only provides an impetus for quality of care, but must also be a strong factor to consider in workplace safety. Interprofessional collaboration can be added to bedside rounding and other existing teams. Successful collaboration enhances workplace safety. Workplace safety rounds will entail attention to the most common types of workplace hazards, including but may not be limited to safety hazards such as those caused by unsafe work conditions and unsafe practices, biological hazards caused by viruses, bacteria, and the like, chemical hazards caused by solid, liquid, or vapor, ergonomic hazards caused by the physiological and psychological demands of the workplace setting on the staff, such as repetitive and forceful movements and awkward postures arising from improper work methods. Physical hazards caused by noise, vibration, radiation, nuclear waste, and most importantly, or one of the more important but less well-known hazards, is psychological hazard that can affect mental health, such as bullying and violence. When making rounds, we must also consider both static or stop position conditions and dynamic or in motion conditions. We make this happen because we realize that true team collaboration enhances a healthy work environment. Additionally, we must assign a priority to the hazards observed to indicate the urgency of the corrective action required. Interprofessional collaboration can be added to bedside rounding and other existing teams. Successful collaboration enhances workplace safety. So all this actually can be identified when making what are called team rounds. In some hospitals and many institutions, actually, because the safety officer does not really want to, quote, bother other disciplines, because he or she feels that that is his or her main role, then they do solo rounds. But that should not or should never be the case anymore. True team collaboration enhances a healthy work environment and is a shared responsibility among different disciplines. The question is, if we know this, Why aren't we practicing it? I think that's the more interesting question. To answer this question, allow me to put on my philosopher's hat. Author David Brooks in The Second Mountain perhaps has deepened my understanding of why knowing does not translate to doing. The author observes that we are living in a world where everybody is free to do whatever he or she wants. Yet most people say they are unhappy. The Second Mountain has enlarged my perspective, and at least for me, gives a more satisfying and enlightening answer to many questions, such as why does knowledge not translate to action on a consistent basis? Brooks observes that the answer may lie not in the lack of knowledge, but in the lack of motivation. The view he presents in his book is counterintuitive, even possibly revolutionary. He opines that individualism is not the path to a happy and moral life, nor is it the mountain we should climb to reach the summit of our existence. In our lives, he says, we have two mountains to conquer. In our younger lives, where many of you find yourselves in, your first mountain is taking your career to a certain level. When one is on the first mountain, the grand narrative is individual emancipation. But the quest for individual freedom leads to the valley of loneliness. It's even called a crisis, even a suffering crisis, which is a debilitating feeling. Nietzsche wrote that he who has a why to live can endure anyhow. The second mountain, then, is the mountain of commitment, where one does what is difficult because it is the right thing to do. Learning how to think or knowing then means learning how to exercise some control over how and what we think. It means being conscious and aware enough to choose what we pay attention to and to choose how we construct meaning from experience. And constructing meaning is the secret sauce to finding motivation. We realize that we can't be happy in solitude. Happiness is relational, and interprofessional work makes these connections possible. We need to waste no more time and start climbing the second mountain. And what kind of ethos is this? The motto of Second Mountain Climbers is shoot for meaning and moral joy, and celebrate interdependence. First mountaineers want to be autonomous and speak with an active voice, take charge, not sharing. Second, mountain climbers praise relations and seek to listen and share. And that's very interprofessional, don't you agree? As I end this talk, I hope you take away the following. First, successful collaboration enhances the workplace and promotes workplace safety. Two, you can change your corner of the world in any role you currently are holding, be it as a frontliner, a middle manager, or the head of your department or hospital. The time, though, to start on this journey to conquer the second mountain is now. As David Brooks says, we think we want ease and comfort. And of course, we do from time to time. But there is something inside us that longs for some calling that requires dedication and sacrifice. So thank you, everyone, and namaste. By the way, I am also an aspiring YouTube vlogger, although I have not uploaded a video in almost a year. But I will take up my little hobby in January of next year. Again, here are my references. And thank you and have a great conference.
Thank you. Dr. Borromeo, for that, for your lecture on the importance of interprofessional collaboration. I think the primary point that our speaker would like to share with us is that interprofessional collaboration not only improves patient safety, but it also enhances workplace safety. So let us now go to our second speaker. So our second speaker is close to my heart because she is not only a colleague, but a fellow alumna who has been very supportive of the UP College of Pharmacy. Ms. Hazel Faye Ardocoyanan is a pharmacist and has a master's degree in pharmacy from UP Manila. She is likewise a multi-awarded health professional in pharmacy in recognition of her dedication, competence, and leadership in advancing pharmacy practice in the Philippines. More recently are the Ishidate Award in Hospital Pharmacy given by the Federation of Asian Pharmaceutical Association and the Lourdes Echao's Leadership Award given by the Philippine Pharmacist Association, both in 2020. So at present, she serves as the chair of the pharmacy services in Makati Medical Center. So ladies and gentlemen, let us now welcome with a virtual round of applause, Ms. Hazel Faye Ardocoyanan.
Good morning. I would like to thank the organizing committee for the kind invitation. It's truly an honor and a privilege to be one of the speakers in this year's Patient Safety Congress. The topic given to me is teamwork in implementing medication safety programs and promoting occupational health and safety. So this is a very interesting topic and medyo heavy. So I hope you will bear with me. I will do my best to be able to discuss and elaborate and hopefully give a meaningful and relevant discussion about medication safety program and promoting occupational health and safety. So for my outline, I'll be discussing medication safety program, collaboration in medication safety program, and promoting occupational health and safety. I believe we all agree in this mantra. First, do no harm. Alam ko itong nasa puso ng bawat isang nandito ngayon. Kaya nga tayo umattend ng Patient Safety Congress because we want to ensure patient safety. This is what's in the heart. Itong nasa puso natin. We want to protect the patient from harm. And in my discussion later, get to realize and understand it is not just about protecting the patient from harm as well as protecting the health professionals involved in providing care to the patient that should also be protected and safe from harm. Okay, so the topic on medication safety is very much close to my heart and I'm sure you will agree with me. Kapag sinabing medication safety, ang unang pumapasok sa atin is about medication error prevention, adverse drug event prevention. But I would like to propose and expand the perspective of looking at medication safety as una sa lahat, bago natin i-prevent ang medication error, is we need to ensure that the medicine that we will give to the patients are of good quality and therefore are safe for consumption or are safe for the patient. And to push it a little further, to make it even more comprehensive, it also involves ensuring that the health professionals involved in providing medications to the patient are likewise protected and safe. So yun ang mag-encompass ng buong medication safety program. Ensuring quality and safe medicines given to the patients, preventing medication errors, looking at the different processes, and ensuring the health professionals providing medications to the patients are well protected and safe. Medicines are used to treat diseases, manage conditions, and relieve symptoms, and they are generally safe when used as prescribed or as directed and when used appropriately. Medications can heal, but we know that medications can also kill if used irrationally and inappropriately. So we need to design and create a medication safety program in our institution so that we'll be able to ensure that the patients are well protected and the patients are prevented from experiencing any harm. Based on CDC, Medication Safety Program monitors adverse events across the country and uses data to improve medication safety through better partnership and policies. As per Joint Commission International, medication safety principle is incorporated in the whole medication management and use program, and it is comprehensive. It includes assessment and evaluation of policies, processes pertaining to medications in all areas of the organization and in each phase of the medication management and use. It involves risk assessment and planning to address and mitigate identified risk, and it is a continuous improvement process. Hence, the key words that you need to keep in mind when you are designing a medication safety program is that it should be comprehensive, and it should involve risk assessment and management, and it should include prospective planning and strategizing to mitigate the risk and implement best practices in medication safety to improve medication management in the organization. This is a high-level portrayal of medication new system. I thought of showing this because when you are designing your medication safety program, you need to look at the different phases of medication use, saan dumaan ang gamot, and make sure that you have a strategy in each phase so that medication errors are prevented and so that medication safety is ensured. So it starts with selecting and procuring the medicine. You need to ensure that you have an established formulary, and this is primarily the responsibility of the clinicians, administrators, specifically the therapeutics committee, as well as the pharmacy department. The next phase is in the storage. This is primarily the responsibility of the pharmacist. You need to have a policy on how to store medicines. And then the medicine will be prescribed by our doctor. It involves assessment of patient, determining of the need for the drug therapy. The next step is preparation and dispensation, and primarily this is the responsibility of the pharmacist. So I need to elaborate that when we talk about dispensing, it's not just about issuance of medicine. Minsan, ang tingin kasi or pagkakaintindi ng iba, ang dispensing parang simpleng pagbigay lang ng gamot. Kuha ka lang ng gamot, siguraduhin mong tama, accurate siya, at bibigay mo na timely manner. But I would like to share with you that dispensing is a more tedious process. It involves several processes. Hindi siya simple. And the first step in dispensing is review of the prescription. We need to make sure that the medicine prescribed is appropriate. We need to double check the dose, the frequency, the route, and check for drug-drug interaction. So those specific details are being done as part of dispensing process. So hindi lang siya about accuracy, timeliness, it's also about ensuring appropriateness of the prescription. So included in this step is the preparation of medicine. Kaya standard of practice is unit dose dispensing, because unit dose dispensing is dispensing the most ready to administer form as possible. So dapat paglabas sa pharmacy as much as possible, ready na siya i-administer ng ating mga nurses, which is a good strategy in preventing errors. So in preparation is also establishing which are the drugs that can be prepared in a simple manner, that can be delegated to the nurses, and which are hazardous drugs that need to be prepared in a negative pressure room, prepared by a trained and competent pharmacist. Okay, the next step would be administration. So primarily, this is the responsibility of our nurses and our doctors. There are drugs that can only be administered by our doctors. And the role of the pharmacist dito, kasama pa rin is, first, we provide guidance, anong tamang dilution, anong tamang stability ng mga gamot, pagkatapos i-prepare, how to properly administer these drugs, so that we work together with the nurses in ensuring that the patient will receive a safe medication and effective medication. The last step would be monitoring. It involves assessment of the patient. So this is interdisciplinary, and it involves the monitoring being done by our doctors, by our nurses, and even the clinical pharmacists, clinical pharmacists. So when you talk about medication safety program, you are reminded of the Swiss cheese model, which shows us that the goal of medication safety is that the holes which represent active failure or the gaps in the system should not align. And the goal is paano mo papaliitin yung mga butas o yung mga gaps sa iyong cheese para hindi dadaan ang error para umabot sa pasyente. What are the different slices of cheese that you need to have in place? Who are the health professionals that can help check in each phase, in each process, so that errors will not reach the patient? And so when we are designing your medication safety program, you need to imagine the different components of the program as the slice of cheese, and you need to look at the different gaps in each slice so that errors will not happen. So the components of the medication safety program include formulary management, storage and inventory management, prescription, transcription, dispensation, preparation, administration, and monitoring. And other components of medication safety program include pharmaceutical waste management, surveillance of the staff, handling hazardous medications, management of adverse drug event, continuous improvement of medication management system, and antimicrobial stewardship program. So hindi lang kasama yung from selection up to monitoring, but we need to make it more holistic, more comprehensive to include management of the waste, pharmaceutical waste, ensuring safety of the health professional handling hazardous medications, how to handle adverse drug event, and even coordinating it with the antimicrobial stewardship program. So let's move on the basic principles and safety practices in MMU of the medication safety program. The first is in formulary management. So you need to define parameters to ensure that the medicines are of good quality and are safe for the patients before you include them in your formulary. Make sure that there is a policy of ensuring that you will only order from legitimate sources, procure from legitimate sources, and you need to know the source of the medicines. Under storage and management, you need to identify processes and ensure safe distribution and receipt of medications from suppliers. Ensure compliance to environmental and storage requirements, which include temperature and humidity monitoring, and especially mga cold chain managed biologicals and medications, close and regular monitoring of temperature is required. So observe and implement good storage practices. You need to have a guideline and include them in your program so that the quality of the medications are maintained until it reaches the patient. So under prescription, practice evidence-based medicine prescribed based on clinical practice guidelines. You need to define your do not use abbreviations. What are abbreviations that you will not allow to use, especially in medication orders? And what are your acceptable abbreviations, and when are these abbreviations allowed to be used in your hospital, in your medication use process? Prescribe using generic name is also helpful, a good strategy, because this is serves as a cross-reference to address sound-alike, look-alike drugs. You should be guided with the elements of a complete medication order. So define ano-ano ang mga elements ng prescription ng medication order to be acceptable so that you are able to minimize vague orders and minimize assumption and misinterpretation of the orders. You can also use technology to help promote safety, such as the computerized decision order entry with mandatory fields para siguradong kompleto yung dose, frequency, and route. And then it can also be integrated with the clinical decision support system to help automatically check the appropriateness of the prescription. So the next is in the transcription. So it's good if you define in your program who is the best person to transcribe the medication order. And as much as possible, if it's, you can eliminate transcription, that would be best practice, because based on studies, most of the medication errors happen during transcription, especially because of the illegible handwriting. No? So kung computerized na ang ating ordering and eliminate transcription, that would be best practice. So we need to remind whoever is doing the transcription to be careful and check for completeness, review before you click and send the order to pharmacy. But dispensing, as what I've said earlier, appropriateness review should be part of the standard of practice in dispensing, part of your medication safety program. Part of the KPI is dispensing medicines accurately and timely, provide drug labels with proper instructions, warning alert to guide the nurses on proper storage, preparation, and administration. You should have strategies to prevent sound-alike, look-alike drug dispensing errors, and when needed, recommendations and pharmacy interventions are given to address drug-related problems identified. Under preparation, of course, part of the standard in the medication safety program is aseptic technique should be observed. You need to follow drug dilution, standard drug dilution, safe preparation practice, part of the medication program. Take note of the appropriate shelf life of drugs in terms of expiration date. Kailan siya dapat quarantine, ano yung acceptable, na i-receive the delivery within 6 months, within 1 year. Shorter than that, hindi na dapat i-receive. Your beyond use date and time, and your in-use time should have a standard part of your program. Label medications after preparation, prepare meds in a safe and clean environment, and identify which hazardous drugs or high-risk medication should be prepared under a sterile environment, clean room, negative pressure, prepared by a pharmacist or a trained health professional. Under administration, ensure right patient by using 2 patient identifiers, validate accuracy of medications prior to administration. So dapat merong first dose validation. Take note of higher medications and have an independent check system. Use infusion pumps to define which are the drugs na dapat naka-infusion pump and be guided with standard administration time. It's a good practice to define what is your standard administration time in your hospital and make it part of your medication safety program. So WHO has actually 5 moments of medication safety. Di ba meron tayong 5 moments of hand hygiene, meron din 5 moments of medication safety from WHO. But this is coming from the perspective of the patient when starting a medicine, taking your medicine, when there's a new medication, reviewing your meds, making sure that you have a list of meds that you have, and when to stop a medicine or what you do in case of missed dose. But it's also good if you can have 5 moments of medication safety from the perspective of the healthcare professional so that medication errors are prevented. And this moment should be the slice of cheese, yung mga moment wherein dapat ka magpupos and mag-check before you proceed to the next step. And these moments are in ordering, dispensing, receiving, preparing, and administering medications. Okay, so the next phase is in monitoring the involvement of the clinical pharmacist. It is best practice if you have clinical pharmacists in your team who will do medication reconciliation, medication order review, drug interaction check, and drug therapy monitoring. Because you need to monitor the response of the patients to medicine, pwedeng positive, pwedeng negative response, no? And give appropriate interventions. You need to monitor the duration of the treatment and report adverse drug reactions and adverse drug events. You should have a program or a strategy or a process on how you will manage adverse drug events that are reported. You need to promote culture of safety and implement non-punitive reporting systems so that you encourage reporting of adverse drug event and medication errors. Identify reportable adverse event, and you should view adverse event and errors in a systems-based approach such that you are able to identify the root causes and strategize to prevent the same errors from happening again. And of course, it's also good that part of your management of adverse drug event, if you can categorize the events based on its severity, taxonomy of medication errors based on the effect of the patient. And of course, you also need part of your program to have a plan on how you will manage the pharmaceutical waste that are generated in the hospital. Segregating pharmaceutical waste and implementing proper waste management treatment process should be part of your medication safety program. And the appropriate PPE when handling pharmaceutical waste. So Clearly, medication management program and medication safety is collaborative in nature, and everyone has a role in medication management. And collaboration is working together to complete the goal of the task. The goal of the team, and the goal is patient care, patient safety. And pag sinabing medication safety program, ang top of mind na iniisip natin na collaborate would be the doctors, the pharmacists, and the nurses. But in reality, it's more complicated, it's more comprehensive than that. It even starts as high as the leadership should be involved in the medication safety program, and the different committees such as the Infection Control Committee and the Recovery Stewardship, even your institutional review board. And the main implementing arm of the medication safety program would be the pharmacy, the nursing services, procurement, inventory, as well as your medical services division. So now let's go to promoting occupational health and safety as part of your medication safety program. So when you think of occupational health and safety, you need to look at your hazardous medications. What are the controls that need to be in place? How would you manage spills and pharmaceutical waste of hazardous medications? And how would you monitor the staff handling hazardous medications? So let's define hazardous drugs. Hazardous drug is a drug that meets one or more of the following characteristics. It's either it's carcinogenic, teratogenic, reproductive toxic, it produces organ toxicity, genotoxicity, structure and toxicity profiles of new drugs that mimic existing drugs, determine the hazardous by the above criteria. So on the right side are the stickers that we place on hazardous drugs so that the one who will handle them would be alerted that it needs special handling. So some examples of hazardous drugs are antineoplastic cytotoxic medications, anesthetic agents, antiviral agents, and others that have been identified as hazardous. The three groups of hazardous drugs are antineoplastic cytotoxic drugs, non-antineoplastic hazardous drugs such as anesthetic, antiviral agents, and others, and drugs with reproductive effects. So the most healthcare workers who are at most risk of harm in handling hazardous drugs are those who prepare and administer them. And this would include the pharmacy and the nursing personnel, the physician, even the OR personnel, environmental service workers, workers in research laboratories, care workers, shipping and receiving personnel. So the potential risk would include skin rashes, adverse reproductive outcome, and possibly leukemia and other cancers. So you need to protect the health workers handling and exposed to hazardous drugs by implementing preventive measures, controls such as engineering controls, administrative controls, and proper protective equipment. So engineering controls include the use of class 2 and 3 biological safety cabinet when preparing hazardous medications. Part of engineering control is the use of the closed system transfer devices and the needleless system. So engineering control uses sterile drug preparation, negative pressure for hazardous drugs, so pwede siyang barrier isolator or a biological safety cabinet. So this is an example of a closed system drug transfer device that mechanically prohibits the transfer of environmental contaminants into the system and escape of the hazardous drug or vapor concentrations outside the system. So they follow one of two design concepts. Pwede siyang physical barrier or air cleaning technology to prevent the escape of hazardous drug. So it is used during compounding and administration, and these are some of the examples of CSTD that we have that we are using. We have the chemoclave, the chemolock. So another engineering control is the needleless system. As early as 2001, there's already a mandate to use needleless IV system in all healthcare settings. So there are three types of needleless IV system used in the US. We have the pre-tear septum or the blunt cannula, then the lower activated device, and the pressure activated safety valve. So these are some of the pictures that I'm sure by this time, especially our nurses, you are familiar with these brands or this needleless technology that we have been using. And these are deemed to promote safety, not just for the patient, but for the health professional. So some more samples of the needleless device. So you need to be careful, be very particular in choosing the needleless IV system, and you should look for the following pictures. The next is PPE or personal protective equipment. It should be used when engineering controls or administrative controls are not feasible. It should always be used in the context of overall health and safety. And this table tells us the type of PPE that needs to be used on the following procedure: single chemotherapy drugs, preparation of containment, primary engineering control, double chemotherapy, protective chemotherapy gown, shoe covers, and hair cover. When administering hazardous medications, you need to also wear protective chemo gown, eye and face protection, respiratory protection, and when disposal, cleaning spills and exposure, double chemo gloves, protective chemo gown, eye and face protection, and respiratory protection. So this is a table that shows the a guideline or the criteria on how you will select the appropriate PPE that you would use for the hazardous drugs. For gloves, dapat chemo gloves that are that pass the standard of American Society of Testing and Materials International Standard. Should be powder-free and should be made of nitrile, polyurethane, neoprene, or latex material. For the gowns, it should be disposable, lint-free to resist chemotherapy. Do not use cloth, laboratory coats, scrubs, or isolation gowns. For eye and face shields, to be worn anytime that there is a risk for splash or spill. Goggles should be worn with face shields when full eye and face protection is needed. Respirators, you need to be familiar what are the hazardous drugs that may vaporize and give that are hazardous at room temperature. So carmustine, cisplatin, cyclophosphamide, etoposide, 5-FU, icosapamide, nitrogen mustard. Surgical masks do not give protection, so you should use respirators that would protect you. Okay, for shoe, the sleeve, and hair and facial hair covers should be lint-free, made from disposable materials. So it's good to be to have part of your medication safety program a guideline on PPE safety, kailan siya dapat pinapalatan, how to inspect, when to wear, removing of shoe covers, use of eyeglasses. And the third one would be the administrative controls. You need to have guidelines and work practices in place as part of your medication safety program. And yan, kasama sa administrative control would be the use of high alert stickers. You should have a spill kit with complete contents. You should have a process on what to do in case of spills, who would be the responders, and how would you manage the spill in your institution. And all of this should be actually part of your medication safety program. And as what I've said, kasama syempre yung proper waste management of pharmaceuticals. And lastly would be medical surveillance. Part of a good medication safety program is to have a medical surveillance that would assess and document symptoms, complaints, physical findings, and lab values to determine whether there is deviation from the expected norms. So it helps in early detection, and it's also used to compare health variables over time of the health professionals exposed in hazardous drugs, and it can also be used to trend in population of workers. So medical surveillance evaluates protection afforded by your engineering control, the administrative control, safe work processes, PPE, and worker education. Okay, so it helps you assess the effectiveness of the different controls that you have in place. So you need to have a guideline on medical surveillance of staff handling hazardous medications, which should be part of your medication safety program. And then lastly is the facility surveillance. So part of this is well, example would be wipe testing. This is part of the USP 800 standard. This would determine whether there are residue of hazardous drugs in the environment or in the surfaces. So this should be regularly done to be able to determine the effectiveness of the controls that you have in your hospital. So for the summary and key takeaways, medication safety program is a comprehensive collaborative medication management and use plan, which involves risk assessment and management to ensure patient safety. Collaboration and an integrated effort are key elements for medication safety program to be effective and successful. Medication safety program should include initiatives to promote and ensure safety of healthcare workers involved in the management and handling of hazardous drugs. And occupational health and safety is a critical component of your medication safety program focused on handling of hazardous medication. So remember, safety starts with you. And thank you very much for listening. These are my reference.
Thank you, Ma'am Hazel. So we actually have questions already, but we will be addressing those questions later after our third speaker. So let me now introduce our third speaker. So after listening to a nurse, a pharmacist, let us now listen to a midwife. Our third speaker is Mr. Jacinto Daniolco Managbanag. So other than his certificate and a Bachelor of Science in Midwifery, he also has a Bachelor of Secondary Education and a Master in Management major in Health Administration. So like our first two speakers, this gentleman is likewise multi-awarded in his field of midwifery. And on top of this list is the outstanding professional in the field of midwifery given by the Professional Regulation Commission in 2016. He is a private practitioner and also serves as a clinical instructor at Asian Development Foundation College. Let us now welcome with a virtual round of applause, Mr. Jacinto Managbanag.
Good morning, everyone. Good morning, everyone. First and foremost, I would like to say thank you very much to the organizer of this third National Patient Safety Congress. Next slide. Sure. My topic is midwife experiences in a birthing facility. So midwife Bantica. Next slide, please. Ito po yung province of Leyte, kung saan yung facility ko is nabilong sa Abuyog, Leyte po. In my province, 41 municipalities, and then as of today, the private birthing facility in Leyte is 42 birthing facility, including my facility. So next slides, please. Ito po yung list ng private practicing midwives in Leyte na under po siya ng Integrated Midwife Association of the Philippines na kumukuha po sila ng good standing po ng IMA. So next slide, please. I'm proud to say my facilities and St. Panakan, there's a vision, goal, and objectives. The vision is to increasing number of happy, healthy, and empowered families. The goal is to ensure that every woman enjoy good health, happiness, dignity and protection from unnecessary death during pregnancy and childbirth and deliveries, nurtures a healthy baby. The objectives are the following: to provide couples with informed choice, voluntarism, compliant, gender fair, safe, and highly quality family planning maintenance services, to increase awareness of mothers and their families to the benefits of timely antenatal visits and facility-based deliveries, to generate involvement from the local government units, schools, and other government and non-government organizations in the provisions of quality and gender fair family maintenance services and their respective settings and localities. And last, to continually expand the numbers of mothers utilizing family planning and maintenance services. Next slides, please. My organizational chart in my facility. My backup obstetricians and obstetricians, Dr. Ludivina Dikit Cabal from Western Leyte Provincial Hospital, Dr. Iris Leonor Enerlan Kulelihan from ACE Medical Center in Tacloban City, Dr. Charlotte Parado Donairi, pediatrician from Western Leyte Provincial Hospital in Baybay City, Dr. Julius Aboyba from Abuyog District Hospital in Abuyog, and I'm proud to say I have a resident Bimong physician, Dr. Milda Marohom. She is a retired municipal health officer in MacArthur Leyte, and now she is visiting in my clinic every Tuesday, Friday, and Saturday. My referral hospitals is Abuyog District Hospital and Western Leyte Provincial Hospitals. Yung clinic ko, yung facility ko, may mga MOA with the ambulances, together with the Rural Health Unit in Abuyog Leyte, Municipal Rural Health Unit in Mahaplag Leyte, Abuyog District Hospital, and Western Leyte Provincial Hospital. All facilities are government facility. So next slides, please. The services offered in Ansing Panakan is normal and spontaneous delivery, prenatal check and postnatal care, family planning services, newborn screening test, and free prenatal vitamins from Vitamin Angels. So nag-grant to ang Ansing Panakan ng Vitamin Angels from USA, and then lahat to ay ibigay po sa mga buntis for free. So next slides, please. As an effective healthcare provider, you should consider to all the following. First is for clients, next is groups, next is community leaders, and last to non-government organizations or other linkages. Next slides, please. As a health provider with the clients, so ito yung ginagawa namin sa mga client namin to establishing a good rapport, to develop trust to your client and commitment. Our client is the light of the business. Ito yung client, you must to treat like a king or queen because the client is the light of the business. So their satisfaction depend on how they market our business. So we should give them our 100% best to your client. So para lang masatisfied sila, 100% satisfied. We should establish the trust, love, and honesty to your client. Hardworking for client with passions must be. So as a male midwife in my facility, ito yung inano ko talaga is to establish rapport to the client because paano yung tiwala nila sa akin bilang isang lalaking midwife, doon tinuruan kami sa UPCHS na maraming lalaking midwife na nagmula doon sa UP talaga. So tinuruan kami on how to deal with the client, on how to develop trust to your clients. So, and last is the commitment. Dapat isang healthcare worker, dapat committed ka sa profession mo. Committed ka to help the mother, to underserved community. Like the UP says, to serve the underserved the community, especially to the mothers in needs. So next slides, please. As a healthcare provider with a group, so ito yung ginagawa namin na to conduct outreach program like Usapan Series. Yung Usapan Series is marami po siyang mga modules, usapan conversations like usapang pwede pa, usapang kontento na, usapang kabataan, at usapang maginoo. So palaging nag-outreach yung Ansing Panakan doon sa mga mothers, out of school youth, kinukuha kami sa mga senior high school students, yung mga for guidance sa mga senior high schools. Yeah. So yun nga, ang ano namin is, hindi lang kami, nag-extend yung services namin sa Ansing Panakan to other group kasi nakakatulong din ito pag pag-market sa aming clinic. And before that, we build as effective service provider by our organization like Integrated Midwives Association of the Philippines, headed by Ma'am Pat Gomez and Ma'am Ason Paras. So maraming trainings na ibigay sa amin, ni-nurture nila kami yung trainings, and then yung mga seminars para lang ma-continuing yung professional education namin as a midwife. And then yung mga update skills namin, yung skills namin, develop yung skills, knowledge, and as well as the attitude. So before that, the UPHS in Palo Leyte, so sila data lang nag-nurture sa amin yung skills nila, knowledge, at saka yung lalo-lalo yung attitudes. And then, sharing of imparting knowledge to the community as a good, para sa mga nanay at saka lalong-lalo sa mga pasyente. So next slides, please. At a healthcare provider with the community leaders. So barangay officials, tanod, BHW. So sa time in UP, tinuruan kami on how to collaborate, on how to coordinate by courtesy call to the other government agencies like barangay captains, mga government NGOs, mga government organizations. So yun nga, tinuruan kami on how to be a community-oriented to the community. So yun nga, closely good coordination and collaboration to the community. Yun po ang pinaka-key para ma-achieve mo yung papunta mo doon sa komunidad mo. So next slides, please. Health provider with other linkages, non-government organizations and GOs, conducting a series of medical missions. So like, it's a very grateful, as a service provider, practitioner, had a very active collaborations to the other linkages or NGOs like municipal mayors, schools principals, civic organizations like International College of Surgeons, headed by Dr. Pora nga dito sa Regionet, and then EMAP, UPMSHS, medicals and nursing students, and other midwifery and nursing schools. So ito yung ginagawa namin since 2015 after Yolanda. So sinabi ng kami mag-asawa, yung asawa ko si Mariros, and then nagtutok kami na how about extend natin yung services doon sa komunidad with the help of other linkages by rendering a series of medical missions. So mula noon, tumawag kami sa UP. So nag-support naman sila kaagad. In 2015, nag-ano kami ng outreach program ng medical missions to the far-flung area, Gida area in Mahaplag, Abuyog, and Nabier. On that time, 2015, nag-start kami, and then 2016 and 2018. But on the other hand, in 2019, 2021, wala kaming na medical mission dahil sa pandemic because of this COVID-19. After that, and lastly, in August 6, 2022, naging successful yung medical mission namin with the International College of Surgeons. Together ni Dr. Pora, siya yung head ng Region 8, and then with the EMAP, other schools na tumutulong sa amin na naging successful yung reproductive health and medical surgical mission namin sa Mahaplag, Leyte, with the mayors, with the other linkages there. And then yun nga, malaki namin pasalamat na tinurture talaga kami, ninurture kami sa UP MSS on how to develop on how to deal with the community. And then next slides, please. What are the lessons we have learned along the way? So mula nung 2010, nag-start yung Ansing Panakan, and 2018, but 2010, So marami kaming natutunan. So una, quality service combined with passion, genuine, compassion, and commitment are good business practices. So number two, strict adherence to legal requirements, quality standards, and policies earned with the partners NAG. Number three, public-private partnership earns you the extra miles. And four, usapan sessions, outreach program, medical missions, mentoring regularly implemented, bring the quantum leap. Yung emphasize ko lang sa number 4, so mentoring regularly. So nag-mentor kami kasi trend of mentoring kami sa EMAP, and then lahat ng mga government midwives, other midwives in the private, nagme-mentor din ako, coaching kami on how to mentor, on how to coach, on how to sharing by my expertise and knowledge to the other midwives. And then tumatanggap din kami yung Ansing Panakan, tumatanggap din kami ng mga midwifery school to na mag-comply ng mga cases na requirements sa PRC during board exam nila. So tinatanggap namin yung UP, yung midwifery students nila for free board and lodging. And then mayroon ding mga ibang school ngayon, so after pandemic, may ibang school na pumasok sa amin, yung Asian Development Foundation, yung Hili Infant College at saka yung Franciscan College Immaculate Conception. So yun nga, and then nag-commit din kami ng aking asawa na magtanggap din kami ng review na sa mga midwifery na gusto mag-take ng board exam na matagal na po silang nagtapos ng midwife na hindi naman siya nag-take ng board exam or kaya ilang beses sila nag-take na hindi nakapasa. So nag-commit kami na magbigay ng special review sa kanila dito sa aming facility with free food and then free, wala yung gastos. So yun nga, nakaano na kami ng 3 beses so far, nakaabot hindi sa inyo is nakaabot ng 80% out of 3, 2 nakapasa. So okay yun sa amin, malaking impact na yan sa amin. And then positive and negative experiences are buds of personal, social, and business growth and development. So next slide, please. Number 7, never lose our passion for excellence. As the saying goes, good, better, best, never let it rest until your good becomes better and your better becomes best. And last, when everything seems hopeless and you feel nothing else works, kneel and down and pray. One should be doing and every day. Anyway, always ask for praise, supplies of strength and godly shower by prayer. So, yun nga, the center po namin is ang pray. Ang sa Panginoon. So prayer lang, hindi lang sa kapakanan ng aming magpamilya, kundi kapakanan sa mga pasyente namin. Yan lang po. At saka yung mga midwives namin. So, next slide please. What are the big impact to the facility? So malaking impact namin sa aming facility yung aming lahat ng ginagawa. So una is to increase antenatal care, postpartum care, and family planning clients, and also deliveries. So hindi naman kami nag-ano sa quantity. Yung namin is ang quality services, yung quality first. Kaya nag-increase yung namin, yung mga clients namin dahil sa quality services na ginagawa namin sa kanila, dinrender namin sa services nila sa mga pasyente namin. To strengthen referral system, especially the one hospital command system. So ito yung namin, specify namin, yung strengthen referral system. Ngayon, tumatawag kami before namin i-refer yung pasyente. And the best practices namin ginagawa namin sa mga pasyente namin. Una, kaya nga yung Ansing Panakan, I proud to present to you na naging sikat yung Ansing Panakan dahil sa ginawa namin ng mga best practices. Ang namin is, yung pasyente, ni-refer namin doon sa hospital, hindi namin hanggang emergency room lang siya. So namin is, may proper endorsement doon sa mga nurses, sa mga doctors doon sa amin, hindi kami uuwi kung hindi pa ma-admit, hindi pa makahiga yung pasyente doon sa kanyang bed doon sa hospital. Kaya kami yung naka-admit. And then, during discharge nila, kasi malayo yung mga pasyente namin, during discharge nila, tatawag sila sa amin a day before sila mag-discharge dahil susunduin namin sila. Kami ang mag-discharge nila doon sa hospital. Kaya nga, kahit hindi nanganak sa amin yung pasyente, makapagbigay ng impormasyon doon sa ibang clients na about sa marketing sa aming pasyente, sa aming clinic rather. And then, strengthening the private partnership when it comes to maternal and health services. So ito, yung Leyte, province of Leyte is meron siyang 10 interlocal health zone na during supportive supervision visit, kasama yung mga private namin dito na ngayon SSB plus na ang tawag sa amin. So kasama yung private na pupuntahan ng government para mag-SSB, supportive supervision. And then yung IMAP naman, yung president ng IMAP dito sa Leyte, kasama din sa pag-supportive supervision, pag-visit, kasama sa government. So malaki yung namin. During interlocal health zone, may mga meetings, may technical meetings, may TWG meetings, kasama yung private nila doon. Yung kasama ng yung maternal and death review, yung clinical case conference, kasama yung private, include yung private talaga. So malaki yung ano namin dito sa Leyte. Mas ano talaga, kaya pasalamat ako sa Provincial Health Office ng Leyte, yung Department of Health Region 8, at saka yung ano talaga, SSB team ng Leyte. So ano talaga, mas maano talaga yung private dito, parang ano talaga na parang recognize nila ng masyado yung private partnership dahil lang po sa organization yung IMAP. And then, known as one of the best services offered facility yung clinic namin. So, basta lang, sinasabi ko nga, susunod lang tayo kung ano yung mga guidelines, protocols ng Department of Health, ng government, ng Provincial Health Office, ano talaga, maging matiwasay yung pagmamalakad natin sa ating facility. So, next slide, please. Ito yung mga achievements as a healthcare provider in my facility. So lahat ng links nandyan po nakalagay. So pwede kayo mag-search din sa Google. I-search mo lang yung pangalan ko, Sinto Managbanag, lalabas na lahat yung mga achievements ko as a healthcare provider. Na future ako sa Singapore, sa UP Manila, yung sa Health Rifles. Maraming salamat sa UP Manila. Ngayon ako yung asipanakan sa Health Rifles nila. So, and then next slide please. Ito po yung ano namin, yung I want to say so, I'm proud midwife. So, ano talaga, proud midwife ako, naggaling ako sa UPHS na nagmula ako sa UPHS and then hanggang ngayon, kahit nakatapos ako sa ibang school, nasa puso pa rin ang UPHS ko. So, next slides. So, thank you very much. And mabuhay po ng Third National Patient Safety Congress.
Thank you, Sir Jacinto. I am sure we are your UP family, especially from the School Health Sciences, is very proud of you. So thank you, sir, for sharing your experiences. And of course, congratulations po sa inyong sa inyong clinic, success of your clinic, and of course the services that you continue to offer to your community.
Thank you po, Ma'am.
So we move on to the exciting part. We move on to the question and answer portion. Our Q&A session, we have already, I know that some of you already sent us questions earlier, and so let me start with okay, so this question is for Miss Hazel. First question, is it recommended for the operating room to have their own pharmacist to handle narcotics?
Good morning po sa ating lahat. Salamat po sa tanong. Ideally, I would say that having a pharmacist in the operating room is a good practice, no? Basically because they handle not just narcotics but other hazardous medications, and the contribution of the pharmacist there would help. Number one, and though the nurses would help. They would be an additional check person, no, to prevent medication errors. They can also do unit dose dispensing of the narcotics para fully maximize yung ating mga narcotics, because we know minsan hindi buong ampule yung pinibigay natin sa pasyente eh. So 0.5 lang instead of 1 ml. So ma-minimize yung wastage and ma-ensure natin yung accuracy. And we can also minimize diversion if you have pharmacists in the operating room.
Okay, thank you. Thank you, Ms. Hazel. There is another question for you here. So given the volume of information contained in a medication safety program, are there strategies we can employ so that health workers would retain them better, especially during practice or emergency cases?
Sabi ko, when I read the question, sabi ko napadami ata yung nilagay ko kasi parang given the volume of information sa MedSafety. I think my answer would be that is the beauty of of implementing medication safety program collaboratively para hindi naka-burden lang sa isang tao ang pag-implement ng medication safety. It has to be collaborative, it has to be interprofessional and interdisciplinary. Other techniques or strategies that can help retain the information or that can ensure efficient implementation of medication safety would be interprofessional round siguro to meron kasi sa amin dito, we make our rounds and we do medication management and use audits just to give them a chance to ask questions regarding how they handle medications. And we also see kung merong problems sa station, sa unit on implementing the medication safety program. You can also, of course, kailangan yung training and kailangan efficient yung or creative yung ating way of informing the team, the nurses, the doctors on the different policies that you have. So pwedeng may infographics, pwede kang merong contest. Sa aming hospital, we have medication safety week wherein we have different activities per week. Pwedeng may contest para ma-instill mo yung kanilang interest in and motivate them to really implement medication safety and uphold. Sabi ko nga, ang talagang nasa puso natin is patient safety. So it's more of reminding them and informing them the policy. And of course, you need to think of creative ways of how you can help them retain all the information and help you succeed in your medication safety program.
Okay, thank you, Ms. Hazel. The next question is for Sir Jacinto naman po. What are the challenges you encountered in your facility when it comes to private-public partnerships?
Thank you, ma'am. So, ma'am, sa amin, ma'am, noong way back 2010, so maraming mga challenges na inano sa amin. Kasi sometimes, ma'am, yung ibang namin noon is kapwa mo ring healthcare worker ang magsiselos, sa inyo kasi yung sinabi ko sa inyo, hindi naman kami i-treat mo kami as a complementor, not a competitor. Kasi yun nga noon, yung sa private mga government midwives, sometimes yung dati sa amin hindi pa strong yung PPP. Hindi namin yung lahat ng nanganak sa aming clinic, hindi nila ininjeksyonan ng for your father yung mga DPP, yung immunization sa mga bata kasi doon daw nanganak sa private. And then yun nga with my nagpunta ko sa Department of Health, nagpunta ko ng PHO pahingi ng tulong. Yun nga, sinasabihan kami ng UP nga, i-collaborate mo doon. Makipagpuntahan mo kagad yung mayor, kung gusto yung mayor, puntahan mo. So with the help of the other agencies, na mataas ng agencies like PHO and DOH, so na-solve yung problem na yan, ma'am. And then, yun lang ang problem namin doon, ma'am. So ngayon, ma'am, ngayon, malaki talaga yung impact namin sa PPP dahil alam mo yung kahit na private kami, ma'am, yung government facility, sila pa maghatid ng pasyente dito namin with the ambulances, yung Bureau of Fire Protections, nag-refer sa amin ng pasyente. With the, talaga, ma'am, is malaki talagang impact sa amin ngayon, ma'am. So kaysa doon, back in 2010, 11, 12, on that time, ma'am, so naka-problema kami, ma'am, on how to deal. Yung lang sa amin, ma'am, no, about sa mga MOAs, yun nga, kami lang sigurong facility dito sa Leyte na yung mga MOAs namin, mga backup physicians, backup, yung referral hospital namin is government. Kasi siguro ang tiwala po nila sa amin, malaki yung tiwala sa aming facility po talaga. So yun lang po, ma'am, ang ko, ma'am, na is yung trust talaga, ma'am, ang importante, ma'am. At saka yung magrespeto ka sa, kahit na private government, respeto ka sa kanila, at saka respetuhin mo yung sarili mo po. Yun lang po, ma'am.
Okay, thank you, sir. We have a question here, but this is on nurses. So siguro kay Dr. Borromeo po ito.
Apologies po kasi yung aking camera
It's okay, ma'am. Okay, at least, ma'am, you're here.
Yes.
So, in the situation now of nurses shortage, what can you suggest on the unbalanced nurse ratio situation, especially in the private settings? Example, 1:10 or more.
Yes, we understand and appreciate the problems that might occur as a result of the shortage. If we look at the root cause naman of the shortage, you will see that these are very fundamental and deep causes. Many of our nurses choose, for example, to leave the country. Reality na po yun. We just need to learn to live with it. The last 2 years have been really problematic because we, as a result of the K-12 transition, kahit na gusto nating magkaroon ng graduates, hindi sila lumabas in the numbers that we envision. So having said all of that and understanding the reasons, ang suggestion namin is this. Number one, keep the role of the nurse in the roles that matter. Meaning to say, hindi na siguro natin dapat gamitin ang nurse for non-value added tasks. Sample, yung bababa siya sa pharmacy to pick up meds. That's not wise use of this very sparse but valuable resource. Yung mag-follow up siya ng doctor's orders. I mean, not orders, but the ano ba yung mga professional fees. Hindi na siguro dapat yan. So at our hospitals, what we have proposed is keep the nurse working at the top of his or her license and only ensure that the nurse is involved in critical matters like medication administration, monitoring and surveillance, health education, discharge planning, and delegate the roles that can be delegated to supplemental staff. Example, yung mga transport issues, picking up things from other departments that wag na po nating ipagawa sa nurse. Just let's concentrate on the real and important and value-added functions of the nurse.
Thank you, ma'am, for responding to that question. Okay, so we have another question for Ma'am Hazel. So we want to know how open are the hospital pharmacy departments to collaborate with pharmacovigilance teams from the pharma industry about patient safety focused projects. Are there any specific ongoing projects or collaborations that you can cite as example? And may we know the communication channel for this type of project?
With regard to siguro mga pharmacovigilance and monitoring activities focused on patient safety, siguro one example that we can have is sa aming hospital, we collaborate closely with the FDA, the regulatory as the regulatory agency of the country. We report all adverse event, adverse drug reaction to them. And part of the practice in our hospital is we also collaborate with the pharma industry. We identify, aside from reporting in our therapeutics committee, we identify the high-risk medications and the meds with the highest number of adverse drug reaction, and we communicate with the company. We give them the report so that we can collaborate and look into and they can gather data ng mga adverse drug reaction ng kanilang products, especially for new products. And we also sometimes give feedback sa company if with regard to their packaging. Minsan kasi madaming mga sound alike, look alike drugs. So pag may problem kami sa packaging, we give feedback. I think that's also a patient safety initiatives that we can embark on. But also, in addition to that, it will be good if we can have a collaboration between professional organizations, siguro. I think that's a good something that we can look at. For example, our organization, PSHP, Philippine Society of Hospital Pharmacists can collaborate with PAPI, the Philippine Association, the pharmacy industry, so that we can have a project on how we can look into medication safety and patient safety. Another collaboration, syempre, from the professional organization, sama dapat si FDA at sa DOH para kung merong maaaring tingnan sa ating policy or sa ating regulations, that we can also give feedback and we can improve medication safety in the country as a whole.
Thank you, Ms. Hazel. So, siguro po ito ang ating last question because we only have until 10:30. This one is for Sir Jacinto. Do the young people of your community see the work that you do? And how do you inspire them to follow in your footsteps? Sir?
Yes, ma'am. Thank you, ma'am. So, sa akin, ma'am, is by continuing commitment sa pagturo sa mga young generation, sa mga young professionals na gusto pang pumasok sa mundo ng mga sa midwifery or other professions like nursing. Kasi yung clinic namin ay kahit nursing nandito nag-comply. So turuan mo talaga sila, lahat ng expertise mo, lahat ng iibigay mo sa kanila para i-mentor mo, i-proper coaching mo sa kanila. And then yun na po, ma'am, is as a good, kung ako ay model, ma'am, is ko nila, ma'am, is by continuing to never stop learning as a healthcare provider. Dapat continue pa rin natin kahit anumang seminars atin tayo, kahit na ganito na, kung iano ko pa nga sa mga estudyante ko, sa mga ng mga professionals niyan, is mas maganda kung mahigitan pa nila ako kaysa ako pa ang mahigit sa kanila. So yun nga, parang 100% ko sa kanila ibuhos yung lahat ng skills at knowledge na nalaman ko sa profesyon ito, ma'am. So yun lang po, ma'am. Ma'am, is yung legacy, yung dapat at least meron akong legacy na maiwan sa kapwa kong mga healthcare provider, ma'am. So yun lang po, ma'am. Ma'am, is ang pinaka-emphasize ko, ma'am, is yung attitude. Kasi gaano ka pang tao, yung skillful ka, knowledgeable ka pa, kung attitude mo is bagsak pa rin, ma'am. So yun lang po ang ko, ma'am, is always that is nandyan yung tatlo. Yung tatlo talaga, yung skills, knowledge, and attitude. Yun lang po, ma'am.
Thank you, sir. So I think it has been a very interesting morning. There are still a couple of questions, but we have limited time. But our speakers could just type in their answers in the Q&A box. No, so you could still, I think you could still send in your questions because anyway, our speakers are with us and they can answer you through our Q&A chat box. So I'd like to, on behalf of the organizing committee of the Patient Safety Congress, I would like to thank our three speakers, Dr. Borromeo, Ms. Docyanan, and Mr. Managbanag, for a very interesting morning and for sharing your knowledge and your expertise, your experiences with us. So again, good morning to everyone. I will be turning over the session, the chairmanship of the session, to the next chair.
Welcome to the 3rd Patient Safety Congress, organized by the University of the Philippines, Manila. Please be reminded of the following rules during the Zoom webinar session. This event is being recorded. You may type your questions in the Q&A box at any time during the lecture. The meeting facilitator will take note of them for discussion during the Q&A session. Kindly revise your name to include your institution. An example for renaming is found here in the slides.
Good morning, and once again, welcome to the simultaneous session 2 of the 3rd National Patient Safety Congress. I am Josephine Carriazo, your session chair, and this morning we are privileged to have with us 3 speakers who will be discussing ways on how we could protect and promote equity among the healthcare workers. To open the session, we have the first UP System Gawad Panghula Awardee for Progressive Teaching and Learning, also a PCP Presidential Awardee for Social Media Advocacy, and just last year, she was awarded the 2021 Metrobank Foundation Outstanding Filipino Teacher. Let us welcome to the virtual floor the current Director of UP Manila Interactive Learning Center, also the Chief of UP Manila College of Medicine Medical Informatics Unit, Dr. Iris Isiptan, who will be discussing safety in telehealth, health worker safety vis-a-vis patient safety. Let us give her a virtual applause.
Thank you. Good morning, everyone. Let me get my slides in order, or Dr. Carriazo will introduce Dr. Abrojena first.
I will introduce her later, ma'am.
So good morning, everyone. There is no patient safety without health worker safety. Let's discuss that in the context of telehealth. And thank you to Diana Lachica for inviting me to give a presentation today. I have no conflicts of interest to disclose. There are many definitions of telehealth, and the term is often used interchangeably with telemedicine. The U.S. Human Health Resources and Services Administration defines telehealth as the use of electronic information communication technologies to support and promote long-distance healthcare, patient and professional health-related education, public health, and health administration. The WHO has defined telemedicine as the delivery of healthcare services where distance is a critical factor by all healthcare professionals using ICT for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and for the continuing education of healthcare providers. Now, there are those who would limit telemedicine only to healthcare services and using the term telehealth if research and continuing education were to be included. And so telehealth would then be the broader umbrella term. So I've divided my presentation into 3. First, a discussion on the risks to patient safety. What is an acceptable level of risk to patient safety with telehealth? Second, how do health workers perceive their safety in telehealth? Does telehealth show massive potential or is it a safety risk? Lastly, how can we normalize telehealth moving forward, mindful of achieving quality of care and safety? So let's start with the risks of patient safety in telecare. Geis et al. Conducted a systematic review which included 22 journal articles, and they identified 11 risks to patient safety in telecare as enumerated here. Change in the nature of clinical work, the lack of patient and or staff knowledge and understanding, technology issues, changes to staff workload, accessibility issues, lack of guidelines, patient dependency, patient anxiety, poor system integration, poor patient compliance, and nature of the home care environment. So let me go briefly through these 11 risks and include what I have seen locally in my pandemic experience of telemedicine. So change in the nature of clinical work refer to safety risk associated with the tasks healthcare staff traditionally perform in the home care setting. For example, the risk associated with the lack of in-person care. Though this systematic review was done in 2014, the lockdowns and quarantines imposed during the pandemic also meant that telemedicine became the only way for patients to see their healthcare team. So definitely this was not an ideal situation given the limitations of a virtual physical exam, which precludes a thorough clinical assessment, making it more difficult to reach good therapeutic decisions. So even more risky was when the pandemic forced healthcare teams to see patients needing emergency care via telemedicine. So ICT also proved a hindrance to good communication and developing good therapeutic relationships, as some health workers found the adjustment from bedside to website manners quite daunting. Next is the lack of patient knowledge and understanding of system functionality and performance. So the patient may be unable to use the telecare system properly, have overconfidence in the capabilities of the system, and not report symptoms. So in my private practice, I have an automatic responder for my clinic email. It informs the patients that the email is not actively monitored since its use is for sending lab requests and prescriptions to them. If they have queries, the automatic response email directs them to contact the clinic phone. So it is risky when the patients would use this email in other ways, like informing me of high blood sugar values or other acute events, where then there can be a delay before I actually open my email and see that. So on the part of the staff, there may be a lack of knowledge on how to interpret and respond to data. In my case, the secretary forwards to me any SMS to the clinic phone that relays symptoms, so I can triage if a face-to-face or ER visit is needed. If I were to delegate this, my secretary will need to have telephone triage training. So there may also be communicative misunderstanding on the goals of the telecare system when staff and patients interpret system functionalities differently. For example, some patients may insist on having their queries managed via SMS when the doctor is already requesting them to go for a face-to-face visit. Next, we have technology issues. Poor technical quality of systems hindered good and timely communication between the healthcare team and patients. This is especially true for us locally because of poor Wi-Fi speeds. Video consultations can become too choppy to be useful. And it is not surprising that technology issues reduce ease of use and user-friendliness. The telemedicine platform I use allows me to shift from video to audio only. So when the Wi-Fi is poor, I visually confirm the patient's identity quickly on the webcam, and then I shift to audio only. Poor reliability is another issue. Wi-Fi can become unpredictable locally. As you know, speeds may drastically reduce when it rains or totally disappear when we have brownouts. So changes to staff workload and associated change to staff roles and responsibilities. So healthcare staff were concerned that the often unforeseen added workloads could affect their ability to perform traditional tasks and responsibilities. For example, in the context of clinical training, do the residents and fellows become less adept at performing physical examinations when patients are mostly seen via telemedicine? But on the other side, can it also be true that their history-taking skills improve because of telemedicine? So accessibility issues refer to problems or delays when trying to contact staff or patients through the telecare technology and problems in receiving user support. So I see my patients via a web browser-based telemedicine platform, which I thought would be easier since the patients wouldn't have to download an app. But if I see that the patients are not able to log in by the agreed time, I text my secretary to call the patient via phone to find out what's happening so that the secretary can then provide technical support. So lack of guidelines. In April 2020, the UP Medical Informatics Unit released the first of its telemedicine guidance documents as physicians were shifting to telemedicine as a pandemic adaptation. So the lack of user protocols is a patient safety risk. And even now, years into the pandemic, we still need clinical practice guidelines and quality assurance systems to ensure both health worker and patient safety in telecare services. Another patient safety risk identified by the systematic review is patient dependency and anxiety. Instead of empowering patients, they can become too dependent on the technology. Monitoring can make patients anxious. So as an endocrinologist, I do have patients who prefer not to relay their blood sugar results regularly via telemedicine, as frequent monitoring actually makes them very anxious. So poor system integration is also a patient safety risk. For example, it's difficult to transfer blood pressure or blood sugar monitoring results directly to the electronic medical records. We have to resort to copy and paste from the patient's email or from the messenger app. I know of some physicians locally who also had their nurses schedule patients via Google Form, but then the nurses don't get feedback anymore about the patient's status afterwards. The systematic review also found that patients may not be motivated to participate in their own care via telemedicine, dissociating from the technology. So when I resumed face-to-face clinic and saw my patients who were lost to follow-up, they acknowledged the risk to their health by not following up via telemedicine, even when I offered the option to them. They expressed that they did not want to deal with the technology or to burden others to help them. So interestingly, the systematic review also found one case study which identified environmental factors as a patient safety risk, where exposed cords for telecare devices were considered a tripping hazard. So next, let's take a look at this study which assessed patient safety in a pediatric telemedicine setting. So this was a retrospective multi-method study of a random sample of 339 parent-physician consultations where the researchers analyzed factors that may have affected the appropriateness of the diagnosis and the reasonableness of the decisions. So the online physicians' decisions were compared also to the subsequent outcomes after each consultation. So the study site was in Israel, where a pediatric telemedicine service was established in 2009. Yes, so many years before the pandemic. Remote medical consultations were available for parents who seek urgent, out-of-hours medical advice for their children via telephone or video chat. And physicians have access to medical records. So essentially, the service is a teletriage, deciding which cases are urgent enough to warrant a referral to the ER and which cases can be addressed by community doctors during regular working hours. So the physicians could give medical instructions and digital prescriptions if necessary for non-urgent cases. So for each consultation, 2 evaluating physicians rated the online physician's diagnosis as either appropriate or inappropriate based solely on the medical data that was available at the time. For example, the symptoms presented during the consultation. So here, diagnostic appropriateness refers to the appropriateness or accuracy of the diagnosis and associated clinical reasoning, but this is not compared to the lab findings and additional medical data that may have been acquired later. And then they also looked at decision reasonableness. So they rated the online physician's therapeutic decision as either reasonable or unreasonable with regards to the specific medical problem based on the online services, clinical protocols, and all available information. Non-medical information included the number of times the online service had been used by the same patient and for the same symptoms, the number of in-person visits to the community clinic regarding these symptoms. So now it's interesting to look at this 2x2 table, as you can see. So the gold standard is on top, the study physician saying whether the patient should have been referred or not referred to the ED or the emergency department. So take a look at this table. So I would be concerned with the false negative. So the cases where the online physician did not refer the patient, but both evaluating physicians wrote that the child should have been referred. We're also looking at the true positive, or the child who should have been referred was referred, right? So if we compute the sensitivity, the percentage of children that were actually referred to the ED by the online physician among all of those who should have been referred, that's about 83%. So remember, I asked at the beginning of this segment, what is an acceptable level of risk to patient safety with telehealth? So are you happy with 83%? Now let's look at specificity, the percentage of children who were not referred to the ED by the online physician out of all the cases that should have been referred. So we have 9 cases who were referred but who should not have been referred. So I would be less worried about this out of an abundance of caution, but the specificity is actually 96%. And if you look at the positive predictive value, the percentage of children who were correctly and necessarily referred to the ED out of those who were actually referred by the online physicians, that's about 91%. And for the negative predictive value, the children who should not have been referred out of all those who were not referred, that's about 93%. And so based on this 2x2 table, the authors concluded that their teletriage service was actually safe. Do you agree? But now let's look at what happened after the referral. So of all the children referred to the emergency department, not everyone actually went. So 68% went, and then most were released after the examination. 13% were hospitalized. So imagine if this 13% had not been teletriaged to go to the ER. So of the children referred to the ED, 31% did not go, but half of those followed up with their community physician, but the other half did not follow up either. So if we were to assume that all these children improved, the authors point out that the true positive would still be high at 68%. So the second part of the study was a qualitative research where 15 physicians were interviewed, and many doctors stated that they used their intuition in the diagnostic process due to not being able to do a physical exam. So the doctors felt that the more experience they have in telemed, the more confident they become. And many physicians stated that they use rules of thumb in their decision-making process and use protocols when available to help maintain patient safety. So what were those non-medical factors they took into account? Well, their impression of the parents, including their level of understanding, the level of anxiety, the health literacy, and the assurance that the parents will act appropriately if the child's condition worsens. And when they were assured, they used additional tools like asking for digital photos or arranging a follow-up call a few hours later. So the pediatric telemedicine study I just discussed is one type of study we can do locally when we're trying to answer what is an acceptable level of risk. But from the point of view of the health worker, does telehealth show massive potential, or is it a safety risk? So in this study, they had 7 semi-structured focus groups with a total of 44 healthcare workers providing care who were both experienced and inexperienced in telehealth. And what's interesting in this study is that the view of the participants varied with the extent of telehealth experience and their perception of accessibility of the healthcare services. So there were 4 themes. So for example, theme 1 is on the workability of telehealth, and it was the urban clinicians, whether experienced or inexperienced, who had reservations about safety, suitability, and limitations, while the residential aged care staff were very positive about it, and also the rural allied health clinicians who saw massive potential to expand the services, interestingly, despite having little or no experience using the technology. So what is an acceptable level of risk to patient safety with telehealth? So the urban clinicians were concerned that if something were to happen, they will not be able to assist the patient. And the example given is, what if you're supervising an exercise and the patient fell down and they're on webcam, so you cannot help the patient? And the novice telehealth urban clinicians were saying, well, if complications were to happen or challenges, will just revert back to face-to-face, but they felt that ongoing experience will be able to help them find new ways of managing these challenges. So the residential aged care staff were not really concerned with safety risk. They were really focused more on the possible good outcomes of telemed. And that was the same also for the rural allied health clinicians and the telehealth clinicians. They were accepting and pragmatic about the risk, which they thought of as something to be planned for and managed. So how about shifting responsibilities and recalibrating the team? So the urban clinicians and the novice urban clinicians felt somebody should be on the ground with the patient. And it was usually the residential aged care staff who took on this role during video conferences, and they felt good about that because they felt it increased their skill levels. And the rural allied health clinicians were also very positive because they wanted to forge links with the urban specialty services. And the telehealth clinicians felt that they needed adequate training for being on-the-ground supporters. Now, how about the change of architecture required to enable integration of the telehealth service delivery? And if we ask the rural allied health clinicians, they said they needed a significant overhaul. And that might be something we will be seeing as well for the Philippines, that we will need to have a change in architecture. So I discussed with you how health worker perception of telehealth varies between groups. But now we will see the last part of my presentation, where I will discuss how quality of care and safety can be attained through telehealth. So there are 5 dimensions we can look at to assess the impact of telemedicine applications. First, there's technical capacity. Is the technology safe and accurate? There's diagnostic accuracy. Does the tech contribute to the correct diagnosis? And there's diagnostic impact. Does the tech provide useful data for diagnosis? So for example, we can compare the fidelity of images sent by phone versus actually seeing it, right? And then the 4th dimension is the therapeutic impact, whether tech influences the patient management of therapy and patient outcome. The tech improves patient health and well-being. So this is actually a study that was conducted in Brazil between a tertiary and a secondary hospital. They wanted to provide support from the ICU and the emergency room department. So the study aimed to describe the impact of telemedicine application on the clinical processes of care. So here, what they did was to review 257 teleconsultation records over a 12-month period versus a similar period prior to the telemedicine implementation. And they had a total of 16 telemedicine physicians to provide 24/7 coverage for the ER, ICU, and they also had medical specialties. Interestingly, when I looked at the telemedicine system, the dedicated broadband connection was only 2 megabytes. So I think that's very practical. So the service was available 24/7. It was up to the remote physician, the physicians in the secondary hospital, whether they wanted to use the service. But what happened was, for every recruited patient, whether transferred or not, they were assessed by the central command through teleconference with an experienced consultant. And they've developed 36 clinical protocols to cover a broad range of common conditions, including sepsis, acute coronary syndrome, stroke, and trauma. So what happened? For 18 patients, the telemedicine consultation influenced making a definite diagnosis. And so telemedicine had diagnostic accuracy and impact. And while for 239 patients, the consultation contributed to clinical management. So that's therapeutic impact. For 15% of the patients, they had a change in antibiotic therapy suggested after telereferral. And after telemedicine implementation, the stroke thrombolysis protocol was applied in 11% of the ischemic stroke patients. And this is actually interesting because before the telemed program, the secondary hospital never had any patient on thrombolysis because there were fears of side effects and liability. But with the telemed program, there were knowledge exchanges that instilled greater confidence in offering thrombolysis. And then the telemedicine approach also reduced the need to transfer the patient to another hospital in 25.9% for a neurological evaluation. So sometimes they said that the secondary hospital would refer to tertiary because they have no neurosurgical service when actually a neurosurgeon is not needed. And so they were able to reduce the referral or transfer. And there was also a 30.4% reduction in mortality in severe sepsis 1 year after the telemedicine was implemented. So how can we normalize telehealth moving forward? So the author suggests that physicians are important gatekeepers in telemedicine adoption and diffusion. We should promote interaction among physicians, build trust, and increase awareness of successful treatments and or mutually agreed indications for teleconsultation, because we need to make the physicians feel safe when they're doing telemedicine. But we also need to support all of the healthcare team, those on the ground, those providing tech support. So as the author said, telemedicine is a tool, not a goal, and it needs to solve a real problem. Medicine is still about people, patients, quality of service, and processes. So thank you very much.
Thank you very much, Dr. Thank you very much, Dr. Iris Isiptan, for that very nice presentation. Well, we have all been witnesses how COVID-19 prevented patients who are non-COVID patients from receiving treatment. And it was indeed telemedicine which assisted them these last 2 years. Thank you for sharing with us the different patient safety issues which you had to face and the different ways you were able to overcome them. And truly, we can say that trust, you have to build the trust of the patient, because it's really hard to be talking to a patient in a camera. You know how it is really very hard, because it's the same for us teachers. It's very hard for us to talk to our students. So I think we know that, of course, the physicians are indeed the gatekeepers, and let us all remember that telemedicine is a tool and not a goal indeed. Thank you very much. So let us give a warm applause to Dr. Iris Isiptan. Now, let us welcome our next speaker. He is currently a faculty of the Ateneo School of Medicine and Public Health, and also a member of the National Board of Trustees for the Philippine Academy of Family Physicians. He will talk to us about ensuring patient and worker safety in the primary care. Let us welcome to the virtual floor Dr. Limuel Abrojena.
Good day. It is my privilege to be once more part of the Patient Safety Congress. For this session, I will discuss the topic on ensuring patient and health worker safety in primary care. These are my disclosures. Here are learning outcomes for this session. Explain the concept of patient safety as it applies to primary care, including its unique issues and challenges. Identify actions or strategies to enhance patient safety in primary care, and analyze the impact of adopting a hybrid patient care model in enhancing patient and health worker safety in primary care. It has been reported that as many as 20 to 25% of the general population experience harm in primary care settings in both developing and developed countries. Various factors contribute towards poor patient safety in primary care settings, including errors in diagnosis, communication breakdown, unsafe medication practices, and fragmentation of care. Patient harm, which is caused by preventable safety lapses, also exerts a considerable health burden across the globe. There is also considerable direct financial cost of harm on health systems. The World Health Organization's International Classification for Patient Safety defines patient safety as the reduction of the risk of unnecessary harm associated with healthcare to an acceptable minimum. An acceptable minimum refers to the collective notions of current knowledge, resources available, and the context in which care is delivered weighed against the risk for non-treatment or other treatment. Patient engagement refers to a set of behaviors by patients, family members, and health professionals, and a set of organizational policies and procedures that foster both the inclusion of patients and family members as active members of the healthcare team, and collaborative partnerships with providers and provider organizations. Primary care is the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. Primary care also describes healthcare that is the first point of contact with the health system for most individuals seeking care. The providers of primary care serve patients of all ages, from children to seniors. Primary care is delivered by a variety of healthcare professionals, including general practitioners, family physicians, nurses, pharmacists, dietitians, physiotherapists, social workers, among others. The concept of patient safety in primary care is focused on the primary care practice as the environment or setting for patient safety to be strengthened. Few identify the healthcare system, such as issues associated with fragmentation of care or continuity of care between acute and primary care settings, and the community, for example, issues associated with community pharmacy or other community level healthcare professionals as determinants of safety. Many identified the need to better understand patient-related factors such as cost of medication that affect a patient's ability to adhere to recommended treatments and therapies. Since face-to-face interactions between patients and providers in primary care settings are limited and may occur weeks to months apart, patients must take greater responsibility in understanding their illness and managing their own health. Four common themes emerge in literature as threats to patient safety in primary care settings: breakdowns in communication, medication-related errors, factors influencing incorrect or incomplete diagnosis, and factors related to fragmentation of the healthcare system. The issue of communication slips and lapses leading to medical error, near misses, and unsafe conditions in primary care was the most widely reported problem. It underlies other issues related to medication management, diagnosis and treatment, and organizational structure and safety, such as fragmentation of care. Communication errors between the patient and the care provider, the patient and the practice staff, and providers and practice staff have all contributed to medical error in primary care. Extending beyond the local practice setting, errors related to communication breakdowns between the primary care practice and other healthcare settings, such as hospital, home care, emergency departments, and community pharmacy, have also been reported as contributing to the patient safety landscape of primary care. Errors within this domain may include errors in referral and errors in communicating test results. Given its ubiquitous relationship to patient safety in primary care environments, strategies to improve communication are at the forefront of patient safety efforts. The target audiences for the interventions have primarily been patients and physicians. Fragmentation has been defined as the lack of standardization and innovation, dissemination, trust, and a safety culture, and is seen as a threat to safety in patient and healthcare system. It also refers to breakdowns in the transition of patients between providers or healthcare settings, with a resulting loss of critical information and valuable time on behalf of the provider and the patient. Patients also have a role in reducing the impact of fragmentation, setting expectations for the patient for the completion of diagnostic tests, and setting timelines for follow-up either via phone or in person are important steps patients can take immediately to improve care. Engaging and empowering patients through partnership was identified as a crucial step to increase patient safety. One of the most widely studied sources of medical error in both acute and non-acute healthcare settings is medication errors. Errors occur at the prescribing, filling, and administration stages of medication management. Prescribing errors included prescribing the wrong medication, prescribing medications with drug-to-drug interactions, and making errors related to transcription of written prescription orders. Filling and administration errors include patients not filling the prescription, patients not understanding why they are on a new or different medication, and patients not taking the medications as prescribed. Diagnostic error in primary care is a complex process with implications for patients and providers, as well as practices and health systems. Diagnostic error has been operationally defined as diagnoses that are unintentionally delayed, such as sufficient information to make a diagnosis was available earlier, wrong, or another diagnosis was made before the correct one, or missed, or no diagnosis was made. Let us discuss identified interventions at the patient, provider, and practice environment level to improve patient and health worker safety in primary care. Let us look at the patient level recommendations. First, ask questions. Preparing patients to ask questions at the office visit is an important first step. Providing opportunities to support question asking, including providers encouraging questions, should be considered. Taking an active role in treatment decisions. Having patients take an active role in treatment decisions is vital to improving patient safety. Active engagement in decision-making includes providing the physician with all the necessary information needed to make a sound clinical judgment. Listening to advice on lifestyle and behavioral factors that may influence poor health, and becoming information seekers rather than just passive recipients of care. Strong support a patient and provider team to encourage patient and accountability in care. They also need to ensure that the patient's voice is being heard. Be prepared to be a patient. Several individuals identified that ensuring that patients are aware of the expectations of being a patient is important. This includes knowing why they are at the doctor, being prepared for the appointment with questions, being open about problems and challenges in the care plan, and bringing a family member or friend with them to the appointment, particularly if expecting bad news. The concept of partnership is tightly coupled with the patient's role in the patient-provider relationship, shifting from a patient listening to a paternalistic doctor to being an active partner. Speak up. One intervention prepares patients with the tools to speak up when something a provider says is unclear or when information is missing or incomplete. The intervention also helps providers make it easy for patients to speak up both when things are good and when they are not. Improve medication understanding and use. A comprehensive approach to patient medications is an important factor influencing patient safety and care quality in primary care. Patients need to know what they are taking, understand why they are taking it, and making sure that they understand the implications of non-adherence. Themes around patient ownership of their medical record were reported by patients, physicians, practice staff, and administrators. Making sure that patients had access to their medical records, most often recommended through a patient portal or other electronic means, was encouraged. Communicate openly. Patients and patient advocates often responded that the ability to have open electronic communication with primary care providers would yield higher levels of engagement and improve patient safety. Electronic communication types identified included email, communication through a patient portal, and the opportunity to text message to the provider. Timely access to providers through the telephone was also encouraged. At the provider's level, the following are recommended. Motivational interviewing. There is a need for strategies to enhance the provider's skills and competencies at coaching, setting goals, and working with patients to agree on health priorities and set realistic expectations. The provider can be a coach or instructor to empower patients and family members to be engaged in their care and become partners. Recommendations also included undergraduate and graduate medical education reform to include skills building around these topics as important first steps in the process. Teach back. Patients and providers felt that an important approach to ensuring understanding of information and encouraging open communication is through the effective and consistent use of teach back. With teach back, when a patient receives new information, the patient teaches that new information back to the provider. Informants recommended using teach back whenever a new medication is prescribed, an old medication is renewed, or a new therapy is discussed. Teachback can also be used to ensure understanding about why a test is being ordered, to reinforce to the patient how important it is to get the test or adhere to the new medication. Shared decision making. Patients and providers identified strongly with efforts to improve shared decision making. Specific strategies or interventions to enable shared decision making were not as common as the identified need for this concept. Contextualized care. Interventions aimed at encouraging identification of patient-level barriers to implementing the care plan are critical to improving safety. These barriers include life preferences, health numeracy, context of care, socioeconomic pressures, and health literacy. Appropriate language. Changing the language used by providers in primary care from medical jargon to living room language was identified by several informants as a key feature to improve patient safety. This approach could help create a sense of equity in decision making and allow patients to better engage in their care. Several approaches identified were aimed to improve patient safety and patient engagement, but required changes in operations, infrastructures, or organization in order to be adopted. We define these approaches as interventions to be applied at the practice setting level, even though they may require individual patient, provider, or practice staff behavior change to be most effectively adopted. Patient portals. Patients, providers, and other healthcare stakeholders agree that a well-functioning, accessible, and usable patient portal is a critical feature that can cross the patient safety, patient engagement chasm in primary care. Information available through the portal should include all the patient's health information and not just selected parts. A patient portal has been identified as an important method of enhancing communication, a vehicle to identify potential errors in information, and a historical record of the plan of care. Informants suggested that the patient portal with access to test results would also allow patients and their family members or caregivers to know when test results arrive at the doctor's office and, more importantly, if they have not. Patient and family advisory councils, boards, or committee models. The idea of engaging patients and families in a structured way to improve the quality, safety, and effectiveness of care in the primary care setting is highly commendable. One physician indicated that it would be ideal for primary care practices to have a patient advisory group. Not all can manage that process, but where they can, they should. Much insight is gained through listening to patients and having them in a leadership role. Team huddles. Efforts to improve communication between physicians, patients, and practice staff is a critical factor to improve patient safety and patient engagement in primary care. Team huddles and other principles of high reliability organizations were recommended to reduce the opportunity for errors in communication, enhance clinical teamwork and effectiveness, and establish practice resilience and ability to respond to unexpected emergencies. Models of team-based care. Team-based care is identified as a critical factor that can improve both patient both patient safety in primary care. Benefits of care teams in these contexts include allowing increased time with patients, fostering meaningful patient-provider relationships, and improving patient and provider satisfaction. Recommended models included nurse, physician extenders, concierge practice model, team screening and taking of medical and social history, team documentation, and coaching and education done by an extended team. In these models, the patients engage with the full team and not just the physicians. Support for shared decision-making. Patients and providers identified shared decision-making as important to improving patient safety and engagement in care. Approaches suggested to support shared decision-making included decision aids, option grids, patient and provider checklists, and other risk tools. Pre-visit labs. Obtaining lab tests before the visit encourages shared decision-making and limits the need for follow-up. Pre-visit labs reduce the risk associated with patients forgetting to have the test done and the risk of the practice team or provider forgetting to follow up on the test results. Usable materials. Providing patients with usable tools they can pick up and take home would help support open communication and decision-making. These included decision aids, patient educational materials, and access to their medical record. However, there is a caution. Decision aids are great for the already activated and educated patients. Providers need to be sensitive to the less educated or health literacy challenged populations and develop strategies to encourage activation among all patient groups. The primary care hazard permeation model is one framework to identify risk to patient safety in primary care. This model focuses on the primary care delivery system within the healthcare environment and builds on the healthcare error proliferation model by adding patient performance as a defensive layer. Thus, it has 5 defensive layers: organizational leadership, provider management, situations for safe practice, provider performance, and patient performance. The 5 defensive layers are organized by proximity to the patient. At the macro level, organizational leadership is the most distant layer from the patient. At the micro level, patient performance is the closest defensive layer to the patient. Latent errors are more likely to occur at the macro end of the primary care delivery system, while active errors are more likely to occur at the micro end. So far, we have discussed the 4 threats to patient safety in primary care settings. We examined strategies identified to close the gaps in safety and those specifically linking enhanced patient and family engagement to improve patient safety in primary care. We now apply this concept in the context of the current COVID-19 pandemic. If you check the latest COVID-19 situation in the Philippines as of September 13, 2022, there are now 3,909,772 reported COVID-19 cases in the country. Of this, 24,502 are active cases. During this date, there were 1,574 new cases added. The COVID-19 pandemic continues to be a threat to both patient and health worker safety, especially in the primary care setting. As presented earlier by Dr. Iris Tan, the COVID-19 pandemic has dramatically accelerated the adoption of telehealth, transforming the patient and practitioner experience. While mostly positive, this transformation has created growing pains as patients and doctors adapted to new technologies and workflows. According to the AMA Digital Health Research, telehealth adoption has already doubled between 2016 and 2019, from 14% to 28%. With the pandemic and aided by the removal of regulatory barriers, the current telehealth adoption is estimated to be between 60 to 90%. But this trend won't last forever. As the pandemic subsides, patients will once again would want to see their doctors face to face. The challenge, of course, is that the healthcare provider is to combine the best aspect for both virtual and in-person care. Thus, the concept of hybrid healthcare that proves more efficient while creating a more rewarding and safe experience for both patient and the healthcare worker. Hybrid care combines the best in-person care and telehealth. It leverages digital technology for teleconsultation, video conferencing, remote monitoring, scheduling, appointments, and follow-up. It is not about switching how a provider sees a patient, which could be through a digital screen or physical interaction. It is also more than telemedicine because hybrid care should be holistic and integrated care experience for patients and healthcare providers, whether as an inpatient, outpatient, while mobile, or at home. A patient's individual circumstances determine the type of care, whether it is virtual, face-to-face, or a combination of the two. The hybrid care model is all about the patient and compels providers to offer both options as long as the patient's condition can be evaluated via telehealth technology. Practices offering virtual care can help reduce patient congestion and provides patients a safer and more convenient way to seek treatment. It can never fully replace inpatient care, but the hybrid approach can readily meet the needs of patients in times when in-person visits may not be doable. While virtual appointments often represent just one of many patient touchpoints, it's critical for healthcare providers to establish comprehensive, interconnected patient workflows to support the combination of telehealth and in-office appointments. These include appointment scheduling, digital patient registration and check-in, automated appointment reminders, two-way patient text communication, and follow-up. How do we set up the hybrid clinic? Determine the protocols and efficient workflow within the clinic, ensuring safety for you, your staff, and your patients. Set up space in your practice to accommodate your telehealth services. Determine when telehealth calls will be available on the schedule, such as throughout the day intermixed with in-person visits, or for a set block of time specifically devoted to virtual visits. Ensure proper documentation of both the in-person consultation and telehealth, preferably using your existing electronic health records, and keeping the patient's medical record together with the patient had in in-person or telehealth consultation. Ensure you receive advance consent from patients for telehealth interactions. This should be documented in the patient's record. Take time to explain to the patient the new setup and how they can maximize the benefits of such services offered. Have a plan for supporting patients on how to access telehealth visits based on your practice's technology and workflow to keep the clinic flow moving and avoid disruptions of care. The tools to make hybrid care effective and seamless for patients are now readily available. Making appointments, registering, and checking in digitally and getting billed are now fast and easy, which reduces delays and frustration. It improves patient satisfaction and engagement because the patient feels their provider is within reach and available. It can also reduce cost by capitalizing on prevention and early detection. Providers caring for high-need patients can use this solution to effectively provide timely and preventive care. Some HMOs offer incentives to providers for their non-face-to-face services. It offers opportunities to tap a new revenue stream from reimbursements. However, there are providers who believe that providing both physical and virtual services may also incur additional cost and burden to them. There is conflicting evidence on this. Some said it reduced cost, while others experienced the opposite. The challenge to practice is they have to invest in the technology and infrastructure to make hybrid care accessible to all. Practices providing hybrid care can readily expand the reach and the quality of their services. Telehealth still has a significant potential for growth. Another feature would be making sure that you can use this as part of your day-to-day activities in the clinic. There are still technology barriers, but there are now remedies. Nowadays, almost everyone has access to a smartphone and a high-speed internet connection. Lastly, the reduced number of inpatient visits enables healthcare workers to be more productive in their tasks. The patient call volume will decrease since virtual care is readily accessible. Moreover, the hybrid care model opens opportunities for remote work. After the pandemic, the majority of healthcare workers have expressed their desire for a hybrid work model if available. Some health workers have implemented new work methods even since the end of 2020. The virtualization of the healthcare workforce during the pandemic has given healthcare workers a chance to reconnect with their families and potentially reduce the incidence of burnout. So what are our key takeaway messages for this session? Patient safety can be improved by addressing numerous issues that occur when patients move between primary and secondary care. In primary care, the relationship between the clinician and the patient is a key to high quality, safe, and effective healthcare. Patient and family engagement in primary care helps to build trusting relationships that promote safety. This presentation focused on various aspects of patient safety and strategies to improve patient safety in primary care and ambulatory settings, highlighting the potential of hybrid patient care model in ensuring patient and health worker safety. Thank you for your attention.
Thank you very much, Dr. Abruhena. I think he gave us a very good description or very good discussion on how primary care, safety in the primary care setting for both patient and the healthcare providers could be addressed. But what is interesting is that he introduced to us this morning the hybrid healthcare. So this, he said, is a combination between telehealth and inpatient treatment. And with the current setting now, with the COVID-19 pandemic, which they said is at least decreasing, now beyond the pandemic period, and with all individuals having their smartphones, then treatment can now be more accessible to a lot of patients, especially in remote areas where the availability even of the primary healthcare providers are almost impossible. But what is important is that he stressed that family and patient engagement is very important for us to maintain patient safety. And lastly, it is also important that we have to remember that in patient safety, the patient is always one of the key stakeholders. So trust, again, like in the presentation of Dr. Iris Isiptan, it is important that the family and the patient develops trust between himself, his family, and his healthcare provider to ensure that patient safety and healthcare provider safety is practiced at all times. Thank you very much, Dr. Abruhena. Let us give him a virtual applause. Now, for our last speaker, let us welcome to the virtual floor a colleague of mine, a psychiatric nurse, also a faculty of the UP Manila College of Nursing, Ms. Maria Angela Mabale.
Good morning. I am Maria Angela A. Mabale from UP College of Nursing, and I am here to discuss about mitigating hazards in mental health clinical practice. Our learning objectives for this discussion are the following: identify clinical risks, and adverse events specific to mental health care. Understand perspectives on safety in psychiatric care, discuss safety practices and implementation strategies, explain ways to optimize environment for behavioral and mental health clients, and discuss important components of risk management. According to the World Health Organization, there are 59 million people who work in healthcare facilities, accounting roughly 12% of the working population. The WHO also reports that all healthcare workers, including healthcare professionals, are exposed to occupational hazards. In the Philippine setting, it is only estimated that 2.2 million Filipino workers in medium and large enterprises enjoy effective occupational safety and health protection and services. This means that 17 of 18 persons in the nation's workforce of 38.8 million do not have acceptable working conditions and are exposed to hazards that predispose them to occupationally related diseases and injuries. The International Labor Organization categorizes occupational health and safety hazards that affect healthcare professionals as biological, such as exposure to bloodborne or airborne pathogens, chemical, exposure to numerous types of chemicals, such as cytotoxic substances, which makes the healthcare professional susceptible to poisoning, allergic reactions, toxicity risks, etc. Physical, falls, noise, and mechanical hazards. Ergonomic, arise from lifting patients and hospital equipment. It also includes the design of the hospital workplace and workstation, working in an awkward work position and repetitive work procedures, and psychosocial, mental and psychological hazards such as stress, as it is evident that healthcare professionals who suffer from stress are likely to suffer from fatigue and exhaustion. A study by Briner and Mansur in 2013 on clinical risk management in mental health management practices mentioned the following clinical risks specific to mental health care. First, violence and aggression. It can be physical or verbal, psychological violence against fellow patients, staff, or other persons. Self-destructive behavior of a patient includes suicide, suicide attempts, self-injury, self-harm, or cutting. Containment measures or compulsory measures that are intended to be an activity to calm down violent patients were also seen as a risk, most especially when there is misuse of seclusion and restraints. Any form of violence with and towards objects such as weapons, lighters, or destroying of furnitures. And leaving against medical advice or absconding wherein the patient escapes from psychiatric clinic that can happen for various reasons. In addition, common errors that pose increased clinical risk in mental health care include diagnostic errors, wherein there is inadequate information about the patient's history, and there is misdiagnosis of physical illness, which could result in incorrect treatment. Preventive errors, inadequate monitoring of patients, and failure to provide prophylactic treatment. Treatment errors, errors in administering treatment and medications, improper care, and avoidable delays in initiating treatment. Medication errors, accumulation, hoarding of medication, and also when there is side effects of medication, this can be a reason for non-compliance. For assessment of suicide risks, and psychosocial risks. The study entitled Psychosocial Risks Related to the Nurse in the Psychiatric Hospital and Management Strategies, Kosafav et al. Identified psychosocial risks investigated according to the following categories: academic training and ability, insufficient education, Courses must constantly review its contents and course load of discipline so that the professional is able to efficiently meet the demands of the patients. Work environment and equipment, such as lack of repairs and maintenance of equipment. Concern with the structure is not based only on the need for personal comfort for everyday activities, but primarily on the desire to improve the patient's care and satisfactorily perform the planned activities. Interpersonal skills. There can be poor relationship with colleagues and supervisors. And we all know that interpersonal relationships among co-workers increases the efficient performance of professionals, being an indispensable item for the quality of care. Workload, overload, long working hours. Monotony, repeatability, slow and fast-paced work, the interference of other works, the permanent attention, supervision, and lack of autonomy are some of the psychological loads. Human resources, such as scarcity, poor distribution of staff, lack of training. Low number of staff members affects the quality of the service, generating risks to the patient safety and to occupational health, being necessary to subsidize the sizing of human resources for patient care with higher quality and safety. Priority should be established in order to overcome the lack of both training and staff members. The participation in specific scientific events and permanent education strategies contribute to reducing psychosocial risk. Work-family interface, conflicts between home and work demands, or little time for family. Factors that interfere in the work-family relationship are the long working hours and the accumulation of functions, which make it difficult for them to spend more time with their family. And violence, fear and physical and emotional abuse. Exposure to situations of violence in the workplace, which brings negative consequences to their performance. Furthermore, experiences of adverse events in patients receiving mental health care include falls, influenced by side effects of psychotropic medications such as sedation, orthostatic hypertension, etc. Assault, wherein studies have found that assault, aggression, or violence from a patient to staff members is more common than the same events directed towards another patient. Sexual contact. Females experience molestation or unwanted sexual comments during their stay in a psychiatric inpatient unit. Self-harm. Common factors are anxiety, depression, and alcohol use disorders. Studies found that environmental restriction increased the risk of self-harm. Other reasons include refusal of a request by staff, feeling of being controlled, conflict with other patients, and disappointed with doctors. Methods of self-harm frequently used in healthcare environments include hanging, jumping, cutting, intentional drug overdose, and strangulation, which often occur in areas of the unit or the ward. Drug adverse events. Most frequent drugs associated with ADRs were anti-epileptics, cardiovascular agents, and second-generation antipsychotics. So, when we cluster or when we group these different factors and risks mentioned earlier, it can be classified to first patient factors, such as acute psychiatric symptoms that can result in impulsive, homicidal, suicidal, and poor judgment behavior, violence, and destructive behavior, risk associated with mental illness and symptoms, and most patients do not believe that they are ill and are therefore in hospitals against their will. That's why there is resistance to treatment and procedures. There are provider factors such as treatment errors, as mentioned earlier, especially in the process of therapy. Workplace stress and mental workload of the staff may impact the patient's safety and treatment. The fear of aggression may result in an increased use of seclusion or restraints, as well as insufficient therapeutic engagement. And the system factors wherein the training programs, human resources, manualized admission and discharge processes, which are mostly beyond the individual control of the care providers, but are relevant to patient safety. So as we continue with our discussion, it is important to understand how the safety discourse became a prominent value in mental health care. It is helpful to consider the historical dynamics from which it emerged. During the era of institutionalization, Goffman asylums and Foucault's madness and civilization offer theoretical perspectives that illuminate the legitimization of practices utilized to control risk and uphold safety and contribute to current understandings of risk management culture in psychiatric care. Despite the frequently articulated benevolent intent of asylums, the discourse of safety reinscribes the notion that individuals with mental illness are dangerous, both incapable of looking after themselves and a threat to the community. According to Goffman, freedom of action, including movement in the outside world, is reframed as a privilege which must be earned through acceptable and safe behavior. According to Foucault, throughout history, societies have variously considered the mad to be evil, idle, and animalistic. Society's fear of mental illness encourages the discourse of safety to flourish, with confinement and unethical practices legitimized through their utility in addressing this articulated need for protection. In the current perspectives on safety in psychiatric care, beginning in the 1950s, the institutionalization in the US and Canada marked a new era in which total and long-term sequestering of individuals within institutions was deemed unethical and asylums were closed. Yet, numerous risk management strategies from the era of institutionalization continue to be utilized, including containment and seclusion. While safety must remain an important component of mental health care, truly supporting the empowering patients within the hospital setting involves discontinuing invasive and harmful practices legitimized through the safety discourse. To change the conceptualization and management of risk in psychiatric inpatient care, the concept of safety itself must be reframed and other care practices and frameworks prioritized. There are two strategies for shifting the safety discourse. The evaluating risk to seek to balance the value of safety with that of therapeutic relationships, and shifting responsibility. Responsibility for safety as shared between healthcare providers and clients involves changing perspectives on where risk is situated. Let us discuss them further one by one. Reevaluating risk. It includes reintroducing the possibility of risk into the clinical setting with harm minimization strategies and a therapeutic goal in mind. Reconceptualizing values in care, risk management strategies that preclude therapeutic engagement with patients, and therapeutic relationship serves to center empathy, listening, and time spent in direct interaction as primary component of treatment. In Chauvet's research on nursing care in psychiatric settings, nurse participants generated a theory of protective empowering, in which safety is not afforded in hierarchical position but remains a crucial component of care alongside therapeutic engagement and advocacy. The concept is framed as protection through helping an individual meet their needs, and this may include reassurance, assisting with self-care, or providing information and choices. However, in mental health settings in which risk for self-harm, violence, and absconding pose genuine threats, Neither must the therapeutic relationship overshadow nurses' attention to the realities of risk. In shifting responsibility, a shift in autonomy and responsibility for care is needed, not only for reducing blame placed on those we are purporting to treat, but also for supporting autonomy itself as a therapeutic intervention. All individuals, regardless of their involuntary status or level of insight, retain residual autonomy, which could serve as a foundation on which to help patients regain their full competence. Next, let us now specify the safety practices and implementation strategies, and the role of the hospital environment, the role of organizational management, the role of the staff, and the role of the patient in patient safety practices. The role of the hospital environment in patient safety. These include regular inspection of items and places in unit where patients can self-harm, and ensuring that the environment is safe or ligature-resistant environment, wherein without points where a cord, rope, bedsheet, or other fabric material can be looped or tied to create a sustainable point of attachment that may result in self-harm or loss of life. Later on, we will discuss this further when we talk about environmental risk management. The role of the organization management in patient safety provides support for the staff and help in creating a good working environment. Enhance learning, teamwork, feedback, and improvement in individual workers' safety and behavior. The role of staff in patient safety. Possess skills to help with the disorders that are being treated in the unit and skills to help patients with self-care. They could be able to provide reassurance and basic information and knowledge about the illness, the treatment, and its administration procedures. The role of the patient in patient safety practices. Establishing a safe therapeutic environment is important for effective patient care and helps to better understand the patient's needs. Inpatients are active in making their environment safer for themselves by avoiding excessive interactions with these individuals or situations, by contributing to the escalating potential risky situations, and seeking surveillance or other safety interventions from staff. A safe care environment should take into account the built environment, organizational culture and policies, patient evaluation and engagement, staff resources and training, emergency management, and error prevention. Let me emphasize the 8 components of a safe care environment. It includes patient assessment and monitoring, staff resources, education and training, space and equipment, emergency management, error prevention, rules, engagement, and culture. This is according to the American Psychiatric Nurses Association's Council of Safe Environments. However, in 2019, the following conditions have been mentioned in an issue brief on safety for behavioral and mental health entitled Reducing Injury and Harm by Taylor and Zbrowski. These are the conditions that may contribute to behavioral and mental health associated harm and elopement. Access to high-risk areas, uncontrolled egress, poor interior visibility, accessibility to patient-occupied areas, unauthorized access to staff or high-risk areas, a lack of secure holding, unsafe finishes or design elements, furnishings and or furniture that can be used for barricades, suicide, projectiles, or entrapment, access to ligature points, systems, electrical fixtures, outlets, doors, etc., and other issues that may contribute to negative patient perceptions, such as institutional lighting, color, signage. These latent conditions can in part be mitigated by a facility design that considers site planning, the building envelope, unit layout, room layout, interior design and finishes, lighting, furnishings, etc. And so that we can eliminate and control the hazardous items and materials and provide a safe and therapeutic environment. So how can we mitigate environmental hazards? Site optimization, wherein there is consideration of risk, often focus on building interior, the building exterior and surrounding area play an important role in mitigating the risk of injury in behavioral mental health populations. The building envelope, such as the facade, windows, and the entrances, the enclosure and protection provided by the building envelope should balance environmental conditions such as the weather, the sun, lighting, with human concerns such as safety and security. Building layout or proximity, adjacencies to high-risk areas, locations that could be used for jumping should always be considered. And in several cases of suicide, patients were able to jump from a roof due to a door that was left unsecured or not easily visible to staff members. Unit layout, visibility. While operational procedures for patient observation may vary, expert opinion suggests that at-risk patients be placed closest to the nursing team station or near staff. Travel patterns to increase in visibility. Communal spaces and bedroom doors should also be observable from central areas. Social density, such as crowding, occupancy, lack of privacy, and loss of control, can contribute to violence in inpatient psychiatric units. Aesthetic and atmosphere. There is emerging evidence for providing a flexible, deinstitutionalized, and home-like environment. So this will greatly benefit our patients so that the environment should be less threatening, should be non-threatening, and conducive for socialization and for relaxation. Unit layout and room type. A complete functional program should establish the needs for patient rooms, ratio of activity areas per patient, number and design of seclusion rooms, and requirements for patient toilets and bathing facilities, in addition to staff spaces, support functions, and other features to support the model of care. So it should include ligature resistance, careful material selection, considerations of the acoustic environment, safe furnitures, mechanical, electrical, and plumbing systems, technology integration, visibility, and secured access. So in optimizing the environment, planning and designing for patients with behavioral and mental health conditions is complex. It is impossible to control for all risks present within a treatment environment. Sometimes patient behavior is predictable, but not always, making these types of design decisions difficult. It is important to strike the balance between a safe and healing environment. As such, a multifactorial approach must consider the interactions of the built environment, the people in the system, both patients and staff, and organizational policies and procedures as layers of protection against risk. In the paper Violence Within Mental Health Services, which aims to present best practice in risk management within mental health services and highlights the current healthcare practices in the UK, England, and Wales, and Ireland, the author specified the 6 basic ideas in risk management. Risk management involves developing flexible strategies aimed at preventing any negative event from occurring, or if it is not possible, minimizing the harm caused. Second, risk management should take into account the risk can be both general and specific, and that good management can reduce and prevent harm. Third, knowledge and understanding of mental health legislation is an important component of risk management. Fourth, the risk management plan should include a summary of all risks identified, formulations of the situations in which identified risks may occur, and actions be taken by practitioners and the service user in response to crisis. Where suitable tools are available, risk management should be based on assessment using the structured clinical judgment approach. Risk assessment is integral to deciding on the most appropriate level of risk management and the right kind of intervention for the service user. The paper also emphasized the term clinical governance. This is a useful tool for assisting quality and safety. It requires action by health providers to ensure the major activities as follows. Risks are avoided, safety is built in, adverse events are rapidly detected, openly investigated, and lessons learned. Good practice is rapidly disseminated, and systems are in place to ensure continuous improvement in clinical care. They also highlighted the term person-centered care. This is another evidence-based element of safer care. This includes understanding of both the mental health issues or illness and all dimensions of the illness experience. Healthcare professionals' understanding of the whole person and his or her needs. Prevention and health promotion are discussed in partnership from the outset and are supported through attention at each consultation or contact. Tools are used to enhance concordance and facilitate good clinician-client relationship. For example, structured, measurable, achievable, realistic, and time-scaled plans are in place for each patient or service use. In working with service user and carers, all staff involved in risk management must be capable of demonstrating sensitivity and competence in relation to diversity in race, faith, age, gender, disability, and sexual orientation. Risk management must always be based on awareness of the capacity of the service user's risk level to change over time, and recognition that each service user requires consistent and individualized approach. In individual practice and team working, risk management plans should be developed by multidisciplinary and multi-agency teams operating in an open, democratic, and transparent culture that embraces reflective practice. All staff involved in risk management should receive relevant training, and a risk management plan is only as good as the time and effort put into communicating its findings to others. Let me end my presentation by sharing to you the 4 fundamentals of risk management. Positive risk management as part of a carefully constructed plan is a required competence for all mental health practitioners. Risk management should be conducted in a spirit of collaboration and based on a relationship between the service user and their carers that is as trusting as possible. Risk management must be built on recognition of the service user's strengths and should emphasize recovery. And risk management requires an organizational strategy as well as efforts by the individual practitioner. That's the end of my presentation. Thank you very much for listening. Here are my references.
Thank you very much, Professor Mabale, for that interesting discussion. So we're about to go over time, so let's just address 2 questions. Okay, anyway, both questions addresses the need for a patient safety officer. So one question, this question actually they said is addressed to anyone. As we strongly promote patient safety, what are the qualifications of what do you think are the qualifications of a patient safety officer? And do you think a patient safety officer plantilla should be in position in government institutions? Anyone?
Let me try to answer the question, Professor Carriazo po.
Thank you, Dr. Abrahena.
Yes, so I think the Department of Health has listed in terms of the requirements regarding the infection prevention and control officer. So we do follow that the requirements at the minimum, at least per institution, especially those with the secondary and tertiary setting. An infectious disease specialist is required to chair the infection prevention and control committee. So now it would be of course difficult in the primary care setting because wala naman tayong ganitong setup. Okay, even in the health centers. Okay, what we have actually is that the Department of Health has a program in terms of teaching the necessary points for the infection prevention and control officer. Now, with regards to the second question, medyo mahirap po yung sagutin kasi yan, issue yan ng Department of Budget and Management, no? But I have scoured through actually looking into are there any department orders or memorandum ba that would somehow open, okay, now that we are on the pandemic response, kailangan ba ng ganitong number tao? And so far wala. Unfortunately, wala akong makita na nag-raise ng ganitong issue on the plantilla. Okay, so maybe perhaps the lessons learned here is that it should enlighten the policymakers to give priority to human resource for health and the implementation of a patient and worker safety culture. Thank you po.
Thank you very much, Dr. Abrojena. Now, there are several questions, but let me just address one more, I think, for Dr. Iris Isiptan. What is the legal protection of healthcare providers of telehealth? At the same time, what is the applicability of legal considerations in delivering telemedicine?
Okay, so as far as the legalities, during the pandemic, there was an issue once that telemedicine will be allowed as part of the practice of medicine while the pandemic is still going on. So since the government hasn't officially declared that the pandemic is over, we are still using that regulation. I think it was an issue once by the Department of Health. Now, what we are looking for is more enduring legislation. Several times the e-health bills have not been approved. Hopefully the next e-health bills will be approved, and that should be inclusive of telemedicine. However, we do have the Universal Healthcare Law, which actually includes telemedicine as a service to be provided. Now, in terms of worrying about legal concerns, we usually talk about getting informed consent as part of the process of telemedicine.
Thank you very much for that, Dr. Iris Tan. I think siguro naman even after the pandemic with the universal health care nga, baka mako-cover na ito. And especially since maganda rin po yung hybrid care wherein you have telemedicine and the inpatient, if we continue on that. Then there's another question which was talking about huddles. Paano daw kung yung person in authority is the person who has removed yung huddle as part of the safety protocol? I think any one of you could answer that, please.
Although I opened up the topic on team huddles, ma'am, on my lecture, so I will answer that. Now, team huddles and other principles of high reliability organizations are recommended to reduce the opportunity for errors in communication, enhance clinical teamwork and effectiveness, and establish practice resilience and ability to respond to unexpected emergency. Now, if this is not the practice of the leader of the organization, he or she may have another leadership style. So in respect to that person, that would allow open communication amongst the team. However, if there were really no opportunity to allow effective communication in the workplace, it will be good for everyone to ask for an audience and resolve this concern with all stakeholders, so it won't become threatening to the person and his or her leadership. Democratic naman tayo sa practice natin. I don't know the other speakers if they have something to add po. Thank you.
Would anyone else like to contribute on this? Well, kasi naman po, like, yes, Dr. Iris.
I see. Ako po, ma'am.
Yes, Angela. Sorry. Yes.
I think I agree with Dr. Abrojena. And for example, sa context ng mental health care, hindi ka talaga magpa-function kung hindi collaborative yung approach and kung hindi team effort. So, involving everyone in the team, naalis yung burden sa isang tao lang para nasa kanya lang nakasentro lahat ng decision. So it's very important na meron talaga tayong consultation process, regular meetings, updates, and yung openness no ng bawat isa to really improve yung mga services natin. Kasi we respond din naman dun sa ano yung mga nangyayari no sa iba't ibang kaganapan sa ating healthcare system. So yun lang po. Thank you.
Thank you very much, Angela. And I think since all of us in the practice, we know how important, siguro iba lang baka naman iba lang yung term, sabi nga ni Dr. Abuhena, baka iba lang yung kanyang manner of doing it. Kasi baka iba lang ang term, kasi yung huddle kasi is a new term which has been introduced when we had the patient safety. But I think it comes together doon sa collaboration when we talk, na-labelan lang siya as huddle, but we all know how important, it has been stressed in all of your discussions, how important collaboration is, and collaboration is with the safety. So kailangan, at na-mention din ni Dr. Abruhena kanina, yung sa transitions of care, kasi ito yung importante with safety, like our patients cannot always be in the hospital. They could be going to a primary setting. So yung this is where collaboration and reconciliation of information, kaya importante ito. So yun po ang aking maidadagdag. And if I think we would have to end our discussion this morning, but it has been a very interesting and very informative discussion. Thank you very much to all our speakers, Dr. Abrahena, Dr. Iris Isiptan, and Ms. Angela Mabale, for a very interesting and informative session. Thank you.
Thank you.
Thank you, everyone.
You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. And lastly, as stewards of patient safety, we are inviting you to sign our pledge of commitment to patient and healthcare worker safety. Please access the link found on your screen.
Reminders for day 2. Please enter the Zoom link for your chosen track on time at 8 a.m. tomorrow. And you may view and vote for the poster presentations and advocacy videos through our website starting today. So the link to the website, the link to the Facebook page are found in the chat box. Thank you, everyone, and see you again tomorrow.
You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. And lastly, as stewards of patient safety, we are inviting you to sign our pledge of commitment to patient and healthcare worker safety. Please access the link found on your screen. You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. And lastly, as stewards of patient safety, we are inviting you to sign our pledge of commitment to patient and healthcare worker safety. Please access the link found on your screen.